Hello students, good evening everyone. I'm audible and visible to all of you. Please update me in the comment section. Yes, so let's begin with the revision for the Obstetrics and Gynecology. I'm Dr. Talib, your faculty for OBGYN. So in this session, we are going to discuss the previous year topics. Okay, the main focus will be on the topic that has been repeated in your exams. So we'll take this revision in a test and discussion manner. We'll be solving first the particular question, and followed by that question, we'll be going into the deep depth explanation of that particular topic. So without any further delay, let's begin with the first question of the day. A hypertensive woman at 8 months of the pregnancy complains of the sudden abdominal pain with bleeding. On examination, the uterine size is above the expected date with the absent fetal heart sounds. And on per abdominal examination, the fetal parts are not easily palpable. The tenderness is noted. The mostly likely diagnosis is. So in a question, it's mentioned that the patient is coming to you with the complaints of the bleeding prior to the delivery. So if a patient is coming to you with the complaints of a bleeding prior to the delivery, we know that it is going to be an antepartum hemorrhage. This is going to be an antepartum hemorrhage. Now the main reasons of this antepartum hemorrhage, if we remember that either this antepartum hemorrhage, it can be a placenta previa, either it can be a vasa previa, or this can be an abruptio placenta, or this can be an abruptio placenta. And whenever the patient comes with the complaints of a painful vaginal bleeding, this is going to be the abruptio placenta. So what is going to be the diagnosis of this particular question, guys? Very good. So it's going to be an abruptio. It's going to be an abruptio placenta. Okay. Now, if you remember from your main classes, we have discussed that abruptio placenta is going to be of two types. One is going to be concealed type of abruption. One is going to be a revealed type of abruption. Now tell me guys, in this question, what is going to be the answer? In this question, what is going to be the answer? So this is going to be very good. This is going to be a revealed abruptio placenta. This is going to be a revealed abruptio placenta. Why? Because the patient is complaining of the bleeding along with the abdominal pain. So painful vaginal bleeding. When the bleeding is coming out, that is going to be a revealed type of abruption. And if this bleeding is within the membranes, I call this, if this bleeding is within the membranes, I called it as a concealed abruption. And if this bleeding is escaping out, and if the patient comes with the bleeding, that is going to be a revealed type of abruption. That is going to be a revealed type of abruption. Now, what can be the other questions that can be asked from this particular topic? Now, so what exactly is an abruptio placenta? Now, if I talk about the definition of this, it's simply a premature separation. It is simply a premature separation of normally implanted placenta, Okay, now all of a sudden this lady will come with a sudden abdominal pain. And what are the risk factors for this particular condition? So the risk factors associated, mainly we have a hypertension. The risk factors: hypertension, elderly gravida, risk factors like trauma, smoking, or the previous abruption. These are all the main risk factors. These are all the main risk factors for the abruptio placenta. As discussed earlier, we have different types of this abruptio placenta. First one, that is going to be concealed abruption. Number second, that is going to be revealed abruption. And we have the most common type or the most common variant of the abruption, that is going to be a mixed variant. That is going to be a mixed variant. Clear to everybody? Yes. So we have a three types: concealed abruption, revealed abruption, and the mixed type of the abruption. Now, if we talk about the concealed abruption, the classical case will be mentioned same like this, but the only difference that differentiates, the only keyword that differentiates the concealed from the revealed, that is going to be the presence of the bleeding. If the question mentions that there is the bleeding present, your answer is going to be the revealed abruption. If the question mentions the bleeding is not present, your answer going to be a concealed abruption. Now, followed by that, what will be the presentation of these patients? So they will complain of painful vaginal bleeding. They will complain of a painful vaginal bleeding, and this will be usually in the third trimester. Because we have studied that the definition of the abruptio placenta, or the definition of an antepartum hemorrhage, it's going to be the bleeding which started from 28 weeks onwards. So what is going to be antepartum hemorrhage? So antepartum hemorrhage is any bleeding from the genital tract from how many weeks onwards? From 28 weeks onwards till the delivery. From 28 weeks onwards till the delivery. And the most common cause for this antepartum hemorrhage, that is going to be a placenta previa. If the question mentions the most common cause for antepartum hemorrhage, that answer is going to be placenta previa. Then answer is going to be the placenta previa. Clear to everybody? Yes. Now, next to that, on per abdominal examination, what will be the per abdominal examination findings of this patient? If you look at the question, it mentions that, sir, the uterine size is above the expected date with an absent fetal heart sound. So remember the height of the uterus on per abdominal examination. The height of the uterus is more than the period of gestation. First one, the height of the uterus, it's more than the period of gestation. Followed by that, uterus is tender. Uterus is tender and ridged. And other findings, so fetal heart sound will be not heard, and fetal parts not palpable. So write down in the chat box if the question mentions a patient is coming with the same complaints that I've mentioned in the particular case, and if it mentions that fetal parts are palpable. If a question mentions that the fetal parts are palpable, what is going to be the answer for that particular question? If the same question comes, a painful vaginal bleeding, and they will mention that fetal parts are easily palpable, your answer is going to be very good. So that is going to be uterine rupture. Now we have a classification that says about the grade of abruptio placenta we have, which says that grade 0, its classification is called as base classification. Grade 0, it is going to be asymptomatic. Grade 0, it's going to be asymptomatic. Grade 1, the patient will complain of pain along with bleeding, but fetal heart sound is going to be normal in that case. Next to that, so grade 2, we have a fetal distress scene. Grade 2, fetal distress scene. And in grade 3, we have a fetal death. Along with a maternal shock along with DIC, along with DIC. And if we talk about this grading, it will be mild. This one is going to be the moderate type of abruptio placenta, and this one is going to be a severe abruptio placenta. And remember that if an examiner asks what is going to be the most common cause for DIC in pregnancy or in obstetrics, your answer is going to be abruptio placenta. Your answer is going to be abruptio placenta. Your answer is going to be abruptio placenta. Now, next to that, what will be the management? Now, anybody in the chat box tell me, if a patient is coming to you in a term pregnancy with the abruptio placenta, what will be your answer for that? So, term pregnancy, your answer is going to be depending upon the parameters given. If a patient is unstable, if a patient is hemodynamically unstable, your answer is going to be always cesarean section. Your answer is always going to be what? Cesarean section. First thing. Followed by that, sir, if a patient is coming and patient is hemodynamically unstable. Now depends at what week. Okay. Now, if a patient is hemodynamically unstable, the answer is going to be cesarean section. Now, if a patient is stable, vitals are normal. Okay, patient is bleeding, but very minimal, and it does not affect the vitals of the patient. Now, sir, if a gestational age is more than 34 weeks, if a gestational age is more than 34 weeks, so what we are going to do? So, we will induce the labor. So, we are going for induction of labor. Now, what exactly is an induction of labor? Induction of labor means that we are going to start the contractions prior to the onset. Okay. And how exactly will start this induction of labor? By artificial rupture of membranes. By artificial rupture of membranes. And artificial rupture of membrane are going to release the prostaglandin and that are going to start the labor. Okay. So, how exactly we perform the normal delivery in abruption? So, the normal delivery in abruption is done by artificial rupture of membranes. Okay, what exactly will happen post artificial rupture of membranes? There will be a release of a prostaglandins. There's going to be a release of prostaglandins, and prostaglandins will induce the labor. Prostaglandins are going to induce the labor. Prostaglandins are going to induce the labor. Now, next is, sir, what if a patient comes with a gestational age less than 34 weeks? Now, less than 34 weeks and patient is hemodynamically stable, continue the pregnancy. Continue the pregnancy. But remember, guys, I have mentioned continue the pregnancy only when a patient is stable. We are learning about when a patient is stable in abruption. So if a gestational age is going to be less than 34 weeks, we continue the pregnancy. And the goal is, what is going to be the goal? So the goal is that to continue pregnancy till 34 weeks. To continue pregnancy more than 34 weeks. To continue the pregnancy more than 34 weeks. Followed by that, less than 34 weeks, we know the fetal lung maturity is going to be important. So we are giving steroids for the fetal lung maturity. How many steroids? So we're giving beta-methasone 2 doses and the dexamethasone 4 doses. Okay. So give steroids for fetal lung maturity. Give steroids for fetal lung maturity. Followed by that, so give magnesium sulfate if less than 32 weeks. Give magnesium sulfate if less than 32 weeks. And make sure that we go for the fetal surveillance. So we have to go for fetal monitoring with non-stress test. What is going to be non-stress test? So there should be 2 accelerations of the 15 beats per minute lasting for 15 seconds over a period of 20 minutes. That is going to be a reactive NST. And if the NST is reactive, that means baby is fine. So we have to monitor fetus with the non-stress test and a biophysical profile. And a biophysical profile, and make sure we monitor the mother as well, because due to the risk of DIC. So there should be a maternal monitoring. There should be a maternal monitoring due to risk of DIC. And as I mentioned, that the most common cause for the DIC in obstetrics, that is going to be abruptio placenta. Abruptio placenta. Why? Because once the placental separation occurs in this abruptio placenta, there is a release of tissue thromboplastin, okay, into the maternal circulation, which increase the risk of the DIC. So that is all about the abruptio placenta. So we had a question that before the pregnancy, a patient came with the complaints of an abdominal pain along with the bleeding. Uterine size was more than the period of gestation. The fetal heart sound was absent, and on per abdominal examination, the fetal parts are not easily palpable. The tenderness is noted. It's mostly likely revealed abruptio placenta. When the answer is going to be a concealed type, if there is no bleeding, then the answer would have been a concealed abruptio placenta. Now, sir, if we look at this picture, in concealed type of abruption, the blood is within the membrane. Are you getting my point? And now this blood is going to enter into the myometrium. This blood is going to enter into the uterine muscle layer or into the uterine myometrium, and it gives a classical picture of this bruised kind of a uterus. And let me know in the chat box, what exactly is this bruised type of uterus called? So this is called as covulate uterus. This is called covulate uterus or bruised uterus And remember, this is not the indication of the hysterectomy. There is no hysterectomy done in abruptio placenta. Right now, let's move to the next question, because we are going into the deep depth explanation of these questions, so that this session should be productive. Are you getting my point? Remember the question followed by that. You remember the answer directly is not going to help you, because the question is not going to repeat. Okay, no matter even if I put the 100 questions in this particular session, the question is not something that is going to repeat. The topic is going to repeat, and they are asking integrated questions, okay, indirect questions. So make sure you know everything about the topic. You remember 30 topics from obstetrics perfectly. That is much better than remembering the superficial 100 topics. Okay, so let's move to the next question. A 32-year-old pregnant woman at 36 weeks gestation presents with the sudden onset severe abdominal pain. Now a lady is coming at 36 weeks with the abdominal pain and the vaginal bleeding. There's a tense, tender uterus. The fetal heart rate monitoring reveals there's going to be fetal bradycardia. What is going to be the next best step? Write down in the chat box. Yes, so just now we have studied that painful vaginal bleeding with the tender uterus. Are you getting my point? With a fetal heart rate monitoring comprised of the fetal bradycardia, that means fetus is unstable. Your classical answer is going to be immediate cesarean delivery. So what will be the answer for this particular question, guys? This is going to be cesarean section. Clear? And what is going to be the diagnosis? So diagnosis is going to be abruptio placenta. What is going to be the diagnosis? Diagnosis is going to be abruptio placenta. So let's move to the next question. Okay, be interactive. Write down the answers in the chat box, every one of you. Chalo. Very good. Now next one, a 32-year-old pregnant woman at 32 weeks of gestation presents with a painless vaginal bleeding. She denies any abdominal pain or uterine contractions. Her vitals are stable. The ultrasound reveals that there's going to be a low-lying placenta partially covering the internal os. What is going to be the most appropriate next step in the management? Now again, prior to the delivery, at 32 weeks, a patient is complaining of a bleeding. but this time the bleeding is painless. So painless vaginal bleeding, you have a two differential diagnosis. One is going to be a vasa previa, one is going to be a placenta previa. Now you already remember that what is going to be the placenta previa. Placenta previa simply means that the placenta is lying or placenta is implanted in the lower uterine segment. That's what the question mentions, that USG reveals that there is a low-lying placenta partially covering the internal os. So this is a diagnosis of, the diagnosis is going to be placenta previa. The diagnosis is going to be placenta previa. And for the placenta previa, what will be the management if a patient is coming to you before term, okay, or the patient is coming to you with the bleeding but vitals are stable? So write down in the chat box, everybody, what will be the answer for this particular question? What will be the answer for this question? Will you go for immediate cesarean delivery at 32 weeks? No. Perform a digital vaginal examination? No. Discharge the patient with a strict follow-up instructions? No. We go with a conservative management. Okay, what exactly is the management? We call it as a McAfee-Johnson regime, that says that we admit the patient, we arrange the blood, we observe the patient, and we give the steroids for the fetal lung maturity. And in case the patient is Rh negative, we give anti-D. So if the vitals are stable, placenta previa, before term, we go with a McAfee-Johnson regime. If the vitals are not stable, or if a placenta previa comes in a term pregnancy, 37 weeks onwards, you mark the cesarean section. So what is going to be the answer? Then you mark the cesarean section. Now let's understand the placenta previa. What exactly is going to be the placenta previa? Now, sir, if we talk about the definition of this, what exactly this means, placenta previa means that placenta, it means placenta is implanted. It means placenta is implanted in the lower uterine segment. Your placenta is implanted in the lower uterine segment. Now depends whether this placenta that is implanted in the lower uterine segment, either partially or completely, either partially or complete, partial or complete. Okay, now depending upon the degree of the extension of the placenta to the lower uterine segment, we have the four types. And this used to be an old classification for this placenta previa, which was called Brownie's classification. क्या बोलते थे इसको बच्चे? Sir, it was called as Brownie's classification. But this Brownie's classification is going to be the old classification. This Brownie's classification is going to be the old classification, which says that type 1, we have lateral type of placenta previa. Type 2, which was called marginal type. It was just away from the os. Okay, type 3, it was partial. That means placenta is covering the internal os partially. And type 4, it was called as complete type of placenta previa. So we had earlier type 1, type 2, type 3 and type 4. But now the new classification says, that we have only two types. We have only two types. One is going to be the placenta, which is going to be the 2 centimeters away from the os. Are you getting my point? And if the placenta is 2 centimeters away from the os, we call this as a low-lying placenta. We call this as low-lying placenta. And low-lying placenta, the older type 1 defines this. Okay, and older 2, 3, 4, that is marginal, partial or complete, that is called as placenta previa now. That is called as placenta previa. That is older type 2, 3 and 4. That is older type 2, type 3 and type 4. Clear to everybody? Now, if we talk about the investigation of choice, for placenta previa, that is going to be transvaginal scan. USG TVS. And for the screening of the placenta previa, for the screening, so we're going to go for trans-abdominal scan. For the investigation of choice, transvaginal scan. For the screening, we can go for the trans-abdominal scan. Now, what will be the clinical features? Now, clinical features are going to be opposite of what we have discussed in abruptio placenta. So, in abruptio placenta, we had a painful vaginal bleeding. Okay, here we have a painless vaginal bleeding. Here we have a painless vaginal bleeding. Okay, next to that, in abruptio placenta, the height of the uterus is more than the period of gestation. Here, the height of the uterus is equal to the period of gestation. It is equal to the period of gestation. Followed by that, in abruptio placenta, the uterus was hard, tender, ridged. Okay, here uterus will be soft. Uterus is soft, relaxed, and non-tender. Uterus is soft, relaxed, and non-tender. That are all the features that the examiner will mention in the question. So, non-tender uterus, relaxed uterus with a painless vaginal bleeding, with the height of the uterus corresponding to the period of gestation, that is going to be a placenta previa. Clear? Now, sir, after diagnosing the placenta previa, if it is more than or equal to 37 weeks, if a patient is coming into the term 37 weeks or 37 weeks onwards, your answer for the management is going to be a cesarean section. Your answer for the management is going to be a cesarean section. Okay, and if in case the question mentions that less than 37 weeks is the period of gestation, make sure you see what exactly is the question mentioning. Okay, less than 37 weeks, you go with a expectant management. You go with expectant management. Now, what exactly is going to be this expectant management? Only answer this expectant management if a patient is hemodynamically stable, if the baby is not in distress, and there is no bleeding which will lead to the vitals unstable, or there is no risk to the mother or no risk to the baby, then only we can go with an expectant management. Other than that, anytime vitals are unstable, hemodynamically patient is unstable, heavy vaginal bleeding actively, you go with a cesarean section. Now, expectant management, sir, it says that you only go with expectant management to continue the pregnancy without risk. You continue the pregnancy without risk. So, what risk can be in these patients? First of all, sir, what if the patient is hemodynamically unstable? So, patient should be hemodynamically stable. Number first thing. Followed by that, number second, there should be no active bleeding. And there should be no fetal distress. There should be no fetal distress and stable vitals. Clear? So that one and the same thing, hemodynamically stable, vitals should be stable. So then only you will answer as an expectant management. And we have a classical regime that we give in case of an placenta previa. This regime is called as McAfee-Johnson regime. So what exactly is McAfee-Johnson regime? So we admit the patient. Okay. Next to that, arrange the blood. Give steroids for fetal lung maturity. Because less than 37 weeks, it can be 30 weeks, it can be 31, it can be 32, it can be 33. So give steroids for fetal lung maturity And how to confirm that fetal lungs are mature? We are going to do with the best test, that is going to be phosphatidyl glycerol. Okay. Yes, we also go for the lecithin sphingomyelin ratio, that should be more than 2:1. We also check for phosphatidyl choline, but if asked best among all, that is going to be phosphatidyl glycerol. Okay. And sir, in order to mature the lungs, we give a drug betamethasone and dexamethasone. Betamethasone, remember how many doses? 2 doses, 12 mg each intramuscular, and dexamethasone 6 mg with 4 doses and intramuscular. This Dexa and betamethasone, they are the drugs that are going to act on the type 2 pneumocytes, and in physio you have studied that type 2 pneumocytes are responsible for the surfactant release, and eventually when the surfactant will release more, the lungs will be mature. In case the lungs are immature, there is less surfactant, that's what we call as hyaline membrane disease or ARDS. Now last thing about this McFay-Johnson regime is that if a patient is Rh negative, you give anti-D. So that's all about the placenta previa. Now let's discuss the next question. Now sir, the same topic, the patient is coming a primi gravida at 37 weeks. Anytime you see the questions from the obstetrics, first thing that you have to see, remember the period of gestation, because in term pregnancy the treatment is going to be different, in a preterm pregnancy treatment is going to be different, and post-term pregnancy the answer can be different, right? So please make sure that you read the full question first and see what exactly is going to be the period of gestation of the patient. So a primi gravida at 37 weeks of gestation reported to the labor room with a marginal anterior placenta previa with painless vaginal bleeding. The fetal heart rate was normal at the time of examination. The best management option for her is. So 37 weeks, a patient is coming to you with the placenta previa. What is going to be your management? Just now we have discussed. Write down the answer in chat box. At 37 weeks, a placenta previa with a painless vaginal bleeding, the heart rate was normal at the time of examination. The best management for this is going to be, very good, that is going to be cesarean section. So we have discussed at 37 weeks, a patient is coming with the painless vaginal bleeding, with the low-lying placenta previa, answer is going to be cesarean section. Can we move to the next question? Yes. We have a lot to cover. Without any further delay, answer me the first question. A 28-year-old woman at 34 weeks of gestation presents with a painless vaginal bleeding. Now again, the painless vaginal bleeding. So far we have discussed the two main causes for the antepartum hemorrhage. If a question mentions the most common cause for antepartum hemorrhage, your answer is going to be placenta previa. If the question mentions the most common cause of DIC in obstetrics, your answer is going to be the abruptio placenta. Now, next question is that at 34 weeks of gestation, patient presents with a painless vaginal bleeding with a fetal bradycardia. Now, fetal bradycardia is seen with a painless vaginal bleeding. On ultrasound, there is a velamentous cord insertion with the fetal vessels crossing the internal cervical os. On USG, we can see that there is a velamentous cord insertion with the fetal vessels crossing the internal cervical os. What is most likely diagnosis? So very easy to catch this one. So V for vasa previa, V for velamentous cord. And when the velamentous cord is present at the os, or there is a fetal vessels crossing the internal cervical os or splitting of the cord at os, this is a classical case for a vasa previa. Sir, placenta previa, there will be a painless vaginal bleeding, but there is no fetal bradycardia, there is no velamentous cord insertion. So placental abruption, there will be a painful vaginal bleeding with a tender uterus. So uterine rupture, the fetal parts will be easily felt, and the patient will have a painful vaginal bleeding. So answer for this particular question, that is going to be a vasa previa. Now, if we talk about what exactly is the vasa previa, so vasa previa means that there is a velamentous cord there is filamentous cord present at os, or the splitting of cord, filamentous type of placenta, the splitting of cord at os, that is going to be vasa previa. And remember the vasa previa, the origin of the bleeding is from the which side? It is from the fetal side. That is why in the question they will mention as well that maybe the baby is in the distress or there is a fetal bradycardia. Now vasa previa is further classified into two types. That is going to be type 1 vasa previa, and type 2 vasa previa. Type 1 vasa previa and type 2 vasa previa. What is type 1 vasa previa? So type 1 vasa previa, it is going to be associated with the filamentous cord insertion. Now if you look at the picture, this is going to be the placenta, this is going to be the cord, and this is a filamentous insertion with the blue color. This is the cord present at os. And you can see over here we have unprotected vessels. Now if we try to deliver this baby with the normal vaginal delivery, there will be more compression of this fetal vessels, right? And eventually it will lead to the fetal distress. Okay. Or if you see that vasa previa, that is going to be type 2, it is associated with the bilobe type of the placentas. Now you see this is going to be the one big lobe, and there is going to be the one small lobe, and this is going to be the connection. And here again there is unprotected fetal vessels. So one big lobe of the placenta and one small lobe, such type of placenta is called as suction ciliate type of placenta. Okay, one big and one small, and these are also associated with a secondary postpartum hemorrhage. Okay, when the retained bits of this placenta remain inside. Right now, sir, what is going to be the presentation of this patient? First of all, as we have mentioned, that patient will complain of a painless vaginal bleeding. Again, this patient is going to complain of a painless vaginal bleeding. Followed by that, there can be a fetal distress scene or fetal bradycardia in the severe cases. Okay, but no tenderness. So we have a patient with a painless vaginal bleeding with the fetal bradycardia or fetal distress with the filamentous cord insertion at the os. This is going to be the classical case for a vasa previa. Can we deliver this patient through a vaginal delivery? No, sir. The classical management, or there's only one management, that is going to be a cesarean section. Now, if the question mentions that patient is in the distress or there is any emergency condition, your answer is emergency cesarean section. If no emergency, or if the vitals are stable, no active bleeding, but there is a vasa previa at 32 weeks, then you can mention that elective cesarean should be planned, or okay, elective cesarean section. Now for the diagnosis of a vasa previa, what is going to be the investigations we do? First of all, we are going to go with a transvaginal scan. We go TVS with a color Doppler. Why Doppler is important? In order to check the blood flow, whether the blood flow is normal or compromised. Followed by that, in order to differentiate whether this bleeding that is coming in vasa previa, whether this blood is from the fetal side or the mother side, so we are going to perform a test which is called as Singer's alkali test or alkaline denaturation test. Now what exactly is this test? So this test is going to differentiate whether the bleeding origin is from the fetal side or the maternal side. Now after performing the Singer's alkali test, if the blood is colorless, that is going to be the maternal blood. If it stays red, that is going to be the fetal blood. What will be the reason for this? Because these fetal RBCs, they are resistant to the alkaline denaturation test. Because these fetal RBCs, they are going to be resistant to the alkaline denaturation test. So we are performing the AP test or alkaline denaturation test. AP test or alkaline denaturation test, which is also called as Singer's alkali test, okay. And sir, this test is to differentiate differentiate maternal and fetal blood. Maternal and fetal blood. If the blood is colorless, this is going to be maternal. If it stays red, this is going to be fetal blood. Okay, and what is going to be the management? The management for the vasa previa, there is always only one answer, that is going to be a cesarean section. That is going to be the cesarean section. Okay, now what will be the answer for this particular question? The next to the topic, a 25-year-old woman at 32 weeks of gestation is diagnosed with a vasa previa. What is the preferred method of delivery in this situation? So a lady is coming to you with the diagnosis of the vasa previa. What will be the answer for this particular question? Everybody in the chat box, what will be the answer for this particular question? A lady is coming to you with the complaints. A lady is coming to you with the diagnosis of the vasa previa. That means there is no emergency at the moment. So what will be the answer? Very good. So if there is no emergency, it's just a diagnosis, we go with the elective cesarean delivery at 34 to 36 weeks. We cannot induce the labor because there are unprotected vessels. That's why the only management is cesarean section. Okay, emergency only when the vitals are unstable. Okay, but other than that, nothing mentioned in the question, just a diagnosis. So we'll plan the elective cesarean at 34 to 36 weeks. The next question, which of the following is the most probable cause of bleeding per vaginum occurring 24 hours after the delivery? Now we are done with the antepartum hemorrhage. We have discussed about the placenta previa, abruptio placenta, and the vasa previa, and focus on the management part, whether a patient is mentioning the complaints in a preterm or term, or the conditions are stable. Whatever we have discussed, when to go for the ARM, when to go for a cesarean, okay, when to go for the emergency cesarean, when to go for an elective cesarean. This is all what we have discussed so far about an antepartum hemorrhage, postpartum hemorrhage, and an abruptio placenta, and all the differentiating key points as per the per abdominal examination and the presentation of the patient. Now next question says that which of the following is the most probable cause of the bleeding per vaginum after 24 hours? Now patient is bleeding after the delivery. Very good. And bleeding after delivery, that is going to be the postpartum hemorrhage. Okay, now this is a classical case of a postpartum hemorrhage, and bleeding after the delivery is postpartum hemorrhage. Till how many weeks? Till 12 weeks. Till how many weeks? Till 12 weeks post delivery. Now after 24 hours, if you remember that the primary PPH is something within 24 hours, and primary PPH is something within 24 hours, and after 24 hours it is going to be the secondary postpartum hemorrhage. For the primary postpartum hemorrhage, we remember that the most common cause is going to be atonic uterus. Most common cause is going to be atonic uterus, and for the secondary postpartum hemorrhage, the most common cause is going to be the retained placental bits, or the retained bits, or the retained placental bits. So what is going to be the answer for this particular question? Which of the following is the most probable cause? Which of the following is the most probable cause? That is going to be retained of placental beds. That is going to be retained of placental beds. Now let's discuss about the postpartum hemorrhage. Now postpartum hemorrhage, it is defined as, the new definition says, blood loss more than 300 ml with the signs of shock. With the signs of shock. What will be the signs? So the signs are, first of all, fetal heart rate of more than 100, okay, or we have shock index more than 1, okay, up to 0.5 to 0.7 is going to be normal, or if the shock index is more than 1, that is going to be the sign of a shock, okay, or the fetal heart rate more than 100, or systolic blood pressure less than 100, or systolic blood pressure less than 100. They are all going to be the causes for the signs of the shock. Or diastolic blood pressure less than 60, or the diastolic blood pressure less than 60. These are all the signs for the shock. And in case the patient is bleeding more than 300 ml with the above signs, this is going to be a postpartum hemorrhage. Or as per the older definition, blood loss more than 500 ml in normal vaginal delivery, or blood loss more than 1000 ml in cesarean section, or blood loss more than 1000 ml in the cesarean section. That is going to be the postpartum hemorrhage. Now, mild postpartum hemorrhage, we have a blood loss up to 500 to 1000 ml. Moderate, the blood loss will be more than 1000 ml. And severe postpartum hemorrhage, it was going to be more than 2000 ml. It's going to be more than 2000 ml of blood. And if a blood loss exceeds more than 1500 ml, we term it as a massive obstetric hemorrhage. Now, what can be this massive obstetric hemorrhage? We have already discussed both these topics. So this means any bleeding related to the pregnancy, and if it is before the delivery, we have termed it as an antepartum hemorrhage, or after the delivery, we have termed it as an postpartum hemorrhage. We have termed this as a postpartum hemorrhage, right? So if a bleeding, whether it is an APH or whether it's a postpartum hemorrhage, if the bleeding exceeds more than 1500, then it is going to be a massive obstetric hemorrhage. Now, sir, if we talk about the causes for this postpartum hemorrhage, we have 4 T's. And what exactly are these 4 T's? We have tone, we have tissue, we have trauma, and we have thrombin deficiency. So we have tissue, tone, trauma, and thrombin deficiency. Now, if we talk about a little bit about this postpartum hemorrhage, and we talk about the cause of this postpartum hemorrhage, it's actually the complication of which stage of labor? Very good. It is going to be a complication of a 3rd stage of labor. Now, 3rd stage of labor says delivery of the baby to the delivery of the placenta, right? Now, sir, in order to decrease the chances of these complications of 3rd stage of labor, such as uterine inversion, postpartum hemorrhage, shock, we go with the active management of 3rd stage of labor. Active management of 3rd stage of labor says that we administer first the uterotonic agent drug like an oxytocin, the most used. Followed by that, what will this oxytocin do? So this is going to maintain the tone of the uterus, because atonic uterus is a most common cause for that. So we give this drug oxytocin. Followed by that, we go with the delayed cord clamping. Followed by that, we deliver the placenta with a controlled cord traction. Now all these steps that we do in active management of 3rd stage of labor is going to decrease the complications, and such a complication is a postpartum hemorrhage, right? Now, the cause of this postpartum hemorrhage, if we talk about the most common in primary, that is going to be atonic uterus. That means the tone of the uterus is decreased. And what are the conditions when the tone of the uterus will get decreased? When we have over distension of the uterus. That is large uterus. Now, what are the conditions a patient is going to have a large uterus? Number first very thing, sir, for example, the patient is having polyhydramnios. The amniotic fluid index is more than 25, or the amniotic fluid is more than 2000. Second, in case of a twin pregnancy, followed by that, in case of a macrosomic baby, macrosomia will be there. That is baby more than 4 kg. Again, the uterus is going to be enlarged. Or in case of a infection of the uterus, that is chorioamnionitis. that is chorioamnionitis. All these are the conditions when the tone of the uterus will get decreased, and the moment the tone of the uterus get decreased, the chances of the postpartum hemorrhage are more. That is why, as per the active management of third stage of labor, we administer the uterotonic agent oxytocin. And in terms of active management of third stage of labor, it's just oxytocin given as a prophylactic drug. Okay, and when you give this oxytocin, we give 5 to 10 units, and in the prophylaxis you can give intramuscular as well, intravenous as well. But remember, when it's given for the treatment of the postpartum hemorrhage, it's given IV drip form. It's given IV in a drip form, because if it's given sudden bolus, it will lead to the cardiac arrest or a hypotension. Now next to that is trauma. What are the traumatic causes for the postpartum hemorrhage? We have the lacerations during the instrumental delivery or during the obstructed labor, or perineal tear during the obstructed labor, or we have hematomas. Now all these causes are going to predispose to the postpartum traumatic causes. Okay, next to that, what if the clotting factors are decreased? Now we have a thrombin deficiency, and in thrombin deficiency we have, first one, we have idiopathic thrombocytic purpura. We have idiopathic thrombocytic purpura. Number second, we have von Willebrand's disease, or we have rarely hemophilias, or we have rarely hemophilias. So in von Willebrand's, we have a factor 8 that is going to be deficient. Then hemophilias, we have, remember, in the path ABC, that is 8, 9 and 11 factor deficient. Next to that, what can be the reasons? That tissues. Now these tissues, they will predispose to the secondary postpartum hemorrhage. Remember that these tissues, they are related to the secondary postpartum hemorrhage, and they are going to be the most common cause for that. And these are retained placental beds. These are retained placental beds. And with this complaint, a patient will complain of the bleeding. With this, a patient will complain of the bleeding after 24 hours. That is what our question mentioned, that after 24 hours, if a patient is complaining of the bleeding, the most probable cause is going to be retained placental beds. It's going to be retained placental beds. Okay, next to that, sir, we have two types depending upon the time. We have two types of postpartum hemorrhage. One is going to be a primary postpartum hemorrhage. Next one is going to be a secondary postpartum hemorrhage. The primary postpartum hemorrhage means that when the bleeding occurs within 24 hours. Within 24 hours of the delivery. I call it as a primary postpartum hemorrhage. What is going to be the secondary postpartum hemorrhage? It means bleeding, what is going to be the most common cause for this? Most common cause for primary postpartum hemorrhage, it is going to be atonic uterus. It's going to be atonic uterus. Okay, next to that, what is secondary postpartum hemorrhage? So secondary postpartum hemorrhage means bleeding after 24 hours. Bleeding after 24 hours. And bleeding after the 24 hours, till how long? Till how long? Anybody in the chat box? Till 12 weeks. Till 12 weeks. That is going to be secondary postpartum hemorrhage. And what is going to be the most common cause for that? So that is retained tissues. That is going to be the retained tissues. Okay, now how to differentiate between whether the postpartum hemorrhage is due to the atonic uterus, or it is due to the traumatic, or it is due to the trauma. So we are going to differentiate it with a per abdominal examination. So first of all, when you do a per abdominal examination and you see the uterus is palpable, and on the per abdominal examination you saw that uterus is palpable. Now palpable uterus, bache, this is going to be the a traumatic postpartum hemorrhage, or this is going to be traumatic cause. This is going to be traumatic PPH. And in case the uterus is not palpable, if uterus is not palpable, If uterus is not palpable, this is going to be atonic postpartum. This is going to be atonic postpartum hemorrhage. So traumatic if the uterus is palpable. If the uterus is not palpable, this is going to be a atonic PPH. Okay. Now, what will be the treatment for this? As we have discussed, first of all, in order to prevent such complications, we go with the active management of third stage of labor. And the first very step was given a prophylactic drug. And what is the prophylactic drug of choice? So we are starting with an oxytocin. We are starting with oxytocin. Remember, methyl ergometrin and other drugs, we are not given in the active management of third stage of labor. And this drug is just given for the prevention. And in the prevention, we can give 5 to 10 international units intramuscular or IV. Intramuscular or IV. That is going to be the prophylactic dose for the oxytocin. Now, if in case the patient is having this postpartum hemorrhage, in case the patient is now having active bleeding postpartum hemorrhage, for first drug that we start is going to be oxytocin. First drug that we is going to start is an oxytocin. Okay. Now, oxytocin, so 20 international units in 500 ml of NS. Remember, you have to give it in a drip form. If in case you give in the bolus form, this is the question, no bolus oxytocin should be given. In case you gave this oxytocin in the bolus form, what will happen? So patient is going to have a sudden hypotension. Patient is going to have a sudden hypotension, or followed by arrhythmias will happen, or cardiac arrest, This is a NEET PG previous year question, that what was the complication, or what is the reason, or what will be the cause of death if a patient will have if the patient will be given a IV bolus oxytocin. So patient will land in the arrhythmias, cardiac arrest, or sudden hypotension. Now, if the first drug is failed, that is going to be oxytocin. Okay, prior to that, remember, uterine massage is given. Prior, uterine massage was a part of active management of third stage of labor, but now it is shifted to the management of the postpartum hemorrhage. Okay. Now, the second drug of choice that we are going to give, that is methyl ergometrin. That is methyl ergometrin. Okay, this is a very good drug, and the peak action is within 90 seconds. We give 0.2 mg intramuscular. We give this drug 0.2 mg intramuscular. But we have a contraindications of this drug. What are the contraindications of this drug? First of all, sir, in case of an hypertension, in case of any heart disease, we will not give, like RHD. Okay. Next to that, we will not give this drug in case of Rh negative pregnancy. Will not give this drug in Rh negative pregnancy, and we will not give this drug before the delivery of the second twin. Will not give this drug before the delivery of second twin. Otherwise, the twin will get stuck. है ना, अगर आपने पहले ही दे दिया. Now, what are the contraindication of these drugs? Methyl ergometrin. Number first one is going to be, if a patient is hypertensive, will not give this drug. This can be the question asked. They can make a clinical case and mention which of the following drug will be contraindicated in the given scenario. Given scenario will be given as a postpartum hemorrhage. And remember, what are the contraindications? Hypertension, heart disease, Rh negative pregnancy, or before the delivery of the second twin. And do remember that as well. Rather mentioning the heart disease or a rheumatic heart disease, they will mention patient is having mitral stenosis. Okay, so it gives you a clear hint about an RHD because the lesion is mitral stenosis only. So then the drug contraindicated is going to be methyl ergometrin. Now, if examiner mentions what is going to be a most potent drug in the postpartum hemorrhage, or what is going to be a drug of choice for the postpartum hemorrhage if a patient is resistant to the routine drugs, then your answer goes with the carboprost. Then your answer goes with the injection carboprost. That is going to be PGF2 alpha. It is a PGF2 alpha. We also give a injection, we give a tablet misoprostol, and misoprostol is a prostaglandin E1. It is prostaglandin E1. We can give rectally, okay, vaginally or orally, but not an injectable. Okay, we can give 1000 micrograms. Followed by that, we can give an injection carboprost, that is PGF2 alpha. And the question was asked in the NEET PG, what is going to be the maximum dose for the injection carboprost? If I talk about single dose, that is 0.25 mg. And sir, we can give a maximum of 8 doses, and maximum of 8 doses, that means the maximum dose we can give is 2 mg. The maximum dose that we can give is 2 mg. That is all about the injection carboprost. Now anybody in the chat box can tell me what is the contraindication of this drug? What is the contraindication of this drug? That is going to be asthma. So carboprost you will not use in the patients of COPD or asthma. Now followed by that, if the medical management is going on, along with that we can also add on the drug that is going to be injection tranexamic acid. Injection tranexamic acid 1 gram IV. Okay, and you have to give it within 3 hours of the bleeding. Okay, followed by that, if a patient is still not having the relief in the bleeding, what if the cause is related to the thrombin deficiency? So we can go with a fresh frozen plasma as well. And that is all about the medical management. But in case now all these drugs that we have given, whether that is an oxytocin, whether that is a methylergomedrin, whether that is a carboprost, misoprostol, okay, if a patient is still not having a relief in case of the bleeding, we go with the mechanical compression. And this mechanical compression we do with the help of this mechanical compression we do with the help of the balloons. And the balloon that we use, it is going to be the Buckley's balloon. You can see in the picture, we inflate the Buckley's balloon inside with the normal saline, warm, normal saline, lukewarm, and then further the balloon will inflate inside, and the pressure over the walls will eventually stop the bleeding. And the question was mentioned that what time you will remove this Buckley balloon? You will remove this after the bleeding is stopped, 12 hours post bleeding is stopped. Okay, so what is this picture given? So this is going to be the Buckley's balloon. This is going to be the Buckley's balloon, and the Buckley balloon, the capacity is going to be 500 ml, and we can remove after 24 hours. Sorry, after 12 hours. After 12 hours. If bleeding stops, remove after 12 hours. We can mention it this way. If bleeding stops, remove after 12 hours. Remove after 12 hours. We can also use Foley's catheter as well. The capacity is around 150 ml. Okay, then we have other ways, other tamponades. We have the synergistic in tube as well, but in India cheaper, we use condoms as well. Clear? So that is all about the mechanical compression. Now if this mechanical compression is failed, we go with a surgical compression, and in the surgical compression we use a sutures called as a compression sutures. Now we use these sutures called as compression sutures, and these compression sutures, which is the most common suture. Now if you see that this is going to be the anterior side, and this is going to be the posterior side. So the principle about this suture is that the anterior and the posterior point should meet, the anterior and the posterior thread should meet at one point. So with these sutures, anteriorly and posteriorly, will compress this uterus so that the bleeding will stop. And the most common suture that we use is going to be the surgical. Most common suture in the compression we use is going to be a B-Lynch suture. So that is going to be the B-Lynch suture. What are the other sutures we use? We use a Heyman suture. Okay, we use a gun shell suture, and we have a sutures over the wall of the uterus in the square type, which is called as a co-square suture, which is called as a co-square suture or toe-square suture. These are all the compression sutures that we use. Now, my dear students, even if the bleeding is not stopped, we go for the devascularization of these arteries, and we are going to ligate these arteries with a order. And what is the order? First of all, so we are going to ligate the uterine artery. We are going to ligate the uterine artery. We are going to ligate the ovarian artery, and we are going to ligate the internal iliac artery. We are going to ligate the internal iliac artery. And which branch of the internal iliac artery we are going to ligate, bache? So we are going to ligate the anterior branch of the internal iliac artery. We are going to ligate the anterior internal iliac branch. If you ligate the posterior internal iliac artery, so patient is going to have a complaint of the numbness, paralysis. Okay, because it is going to supply the lower limb side. Okay, now sir, the anatomical question can be asked in an integrated manner. Which of the following arteries you will not ligate? Okay, so remember, do not ligate the branch of the posterior one. Do not ligate. Okay, now what are the arteries you're not gonna ligate? What are the arteries you're not going to ligate? Number first one is going to be a superior gluteal. Number first one is going to be a superior gluteal. Number second, that is going to be iliolumbar. Number second, that is going to be iliolumbar. And third one, that is going to be lateral sacral. These are all the branches of the posterior internal iliac artery. They are the branch of the posterior internal iliac artery. Is that clear? Clear to everybody? And if still the bleeding is not stopped, then the last option is going to be the hysterectomy. The last option is going to be hysterectomy. We'll remove first the uterus only. If not, then uterus plus cervix. Now, my final question to all the students who are watching. Now, tell me that a patient is having a ligation of this uterine artery. You stop the blood supply, because the main two arteries that are going to supply the blood to uterus is going to be uterine artery and the ovarian artery. But we ligated this uterine and ovarian artery. Now, from where exactly the uterus is receiving the blood supply? Anybody in the chat box? Now, bache, we ligated the uterine artery and ovarian artery, right? Uterine artery, ovarian artery is ligated. Now, sir, what is going to be the artery that is going to supply the uterus? Anybody in the chat box? Uterine artery and ovarian artery is ligated. Now, what is going to be the blood supply for the uterus? Which artery is going to contribute? Anybody in the chat box? Yes. If the artery of uterine artery and the ovarian artery is ligated in postpartum hemorrhage. Now, from where exactly this uterus is going to have a blood supply now? Okay, so that is going to be the artery of round ligament, also called as Samson's artery. So what is the answer? So the artery of, I will write here, artery of round ligament. Also called as Samson's artery. So that is all about the postpartum hemorrhage. Clear to everybody? Yes. Now, next to that is the question. Now, answer me this particular question in the chat box. A 25-year-old lady, a 25-year-old woman with the postpartum hemorrhage due to uterine atony does not respond to the uterine massage or the pharmacological treatment, what is the next step? Now, this has been the previous year question in NEET PG as well as FMG. Now, you have a lady, because we have discussed everything about the postpartum hemorrhage so far. Now, you have a lady coming to you, and lady is having bleeding after the delivery. She's a case of a postpartum hemorrhage, and in case the pharmacological treatment, whatever drugs you have been given so far, they're not working. Okay, so what is the next step? Write down in the chat box. What is going to be the next step? What is going to be the next step, bache? Everyone, what is going to be the next step in the management? Sir, the next step in the management is going to be, very good, it's going to be balloon tamponades. It's going to be the balloon tamponades. It's going to be the balloon tamponades. And balloon tamponades, we can use Bakri balloon or stick in tube, or we can use condom catheters. Okay, and now after Bakri balloon, what will be the answer? Then we have a compression sutures. After that, artery ligation, uterine artery, ovarian artery, internal iliac, anterior. After that, then the last is going to be hysterectomy. One more point, what is the best method to prevent postpartum hemorrhage? Anyone in the chat box? Best method to prevent postpartum hemorrhage. What will be the answer? Best method to prevent postpartum hemorrhage. So that is going to be the active management of third stage of labor. That is going to be active management of third stage of labor. That is going to be active management of third stage of labor. Okay, and what is the best treatment at the end if the family is complete? What is going to be the best treatment if the family is complete? What is going to be the best treatment? Then hysterectomy. Next question. Yes. So what will be the answer for this particular question? A 28-year-old woman presents to the labor ward in an active labor and delivers a healthy baby vaginally. During the delivery of the placenta, there is a sudden onset of the profuse vaginal bleeding. Now, once a baby was delivered, now we are going to deliver the placenta with a controlled contraction. But during the delivery of the placenta, there was sudden onset of the profuse vaginal bleeding with a severe abdominal pain. Okay. Now, the attending physician notes that the uterine fundus is not palpable. Now, when a doctor, the physician is palpating the fundus, he is not able to palpate the fundus, and he's seeing that there is a cup-like depression in the fundus. Why there is a cup-like depression in the fundus? Because there should be a uterus normally, but now that uterus was in the vagina or outside the vagina. So, the uterine fundus is not palpable because of the uterus outside, and on inspection, he saw that there is a fleshy mass seen protruding from the vagina. That he saw this fleshy mass is outside. And now, what is this fleshy mass? You can see here, this fleshy mass, that is going to be the uterus. And what is the condition when there is an upside down of the uterus? When there is an upside down of the uterus or upside down of the uterine fundus into the cavity, that is going to be a uterine inversion. So what exactly is the diagnosis for this condition, bache? What exactly is the diagnosis for this condition? So this is going to be the uterine inversion. This is going to be a uterine inversion. Clear? Now, sir, what is this uterine inversion? Now, let's understand what exactly this uterine inversion is. Now, if we talk about the definition of this uterine inversion, this simply means that there is a prolapse of the fundus. Now, bache, if you can see in the image, if this is the uterus, okay, what exactly is the uterine inversion? This is the uterine inversion. That means turning upside down of the uterus, right? But uterus is outside. In prolapse, uterus is also outside. But in prolapse, when the main ligaments that support the uterus, whether it's a pubocervical ligament, cardinal or uterosacral ligament, when the support of the uterus gets weak, okay, or the pelvic floor gets weak, levator ani muscle gets weak, this uterus start descending down, like step 1, stage 1, stage 2, stage 3, stage 4, depending upon that we'll discuss in the uterine prolapse chapter, what exactly we call this as a Shaw's classification. Okay, and then the last one, procedentia. So inversion simply means turning upside down, and prolapse means descending step by step down. And then at the level of introitus, below the level of introitus. That's what we'll discuss in the next topic about uterine prolapse. Now, sir, inversion is defined as, in both the conditions, uterus will be outside. Now, inversion is defined as prolapse of fundus. Inversion is defined as prolapse of fundus of the uterus into uterine cavity. Okay, now first patient will immediately go into the shock. Okay, post delivery patient will immediately go into the shock. Now patient immediately goes into the neurogenic shock first. And then followed by hemorrhagic shock. The first patient goes in the neurogenic shock, followed by that patient goes into the hemorrhagic shock, Now, if you ask the most common cause of death, that is going to be a hemorrhagic shock. Now, what are the causes for this particular condition, uterine inversion? The most common cause is mismanaged third stage of labor. The most common cause is going to be mismanaged third stage of labor. The most common cause is going to be mismanaged third stage of labor. Followed by that, what can be the other causes for this uterine inversion? Sometimes this placenta is so adherent due to the absence of the decidua basalis. This placenta, it invades the myometrium and it goes up to the pelvic structures. We call those placenta as an adherent placenta, right? Now that badly adherent placenta will not be able to deliver normally. So when you try to remove that placenta, along with the placenta, sometimes uterus also comes out. So the other cause can be the badly adherent placenta, like increta, accreta, and parcreta. Badly adherent placenta. Okay, and followed by that, so rather going for control cord traction, if we go for sudden cord traction, what will happen? Ya to cord prolapse hoga, ya to cord break hoga, or either so the uterus will turn upside down. So we'll have a sudden cord traction, or we'll have a uterine inversion due to the sudden cord traction, or the uterine atony, will be the cause, Okay, now these are all the main causes for the uterine inversion. Now when you do the per vaginal examination of these patients, you will see the patient is bleeding, plus there will be mass in vagina. Now what exactly is this mass in vagina? So it is a uterus which has been prolapsed. Okay, now next to that, on per abdominal examination, you will see cup-like depression. Or the examiner will mention fundus is depressed. It will mention fundus is depressed. So fundus is depressed again, so that is going to be the case of a uterine inversion. Now what will be the management of these patients? First of all, remember that patient immediately goes into the shock when there is a case of a uterine inversion, and in this scenario, first the patient goes into the neurogenic shock followed by hemorrhagic shock. So in the management, always remember the first thing you have to go is resuscitation. Okay, secure the IV line and make patient hemodynamically stable, then followed by that, try to repose it as soon as possible. This uterus as soon as possible. Now you take this uterus and try to push it manually back into its normal position. We call this manual reposition, as a Johnson's maneuver. You can see in the picture A, step number first, you hold the uterus. Step number 2, use the other hand as a supporting hand and push it in. And step number 3, we push with the fist back to its normal position. And this maneuver is called as, if the picture will be given, the classical maneuver is performed in which scenario? What is your answer? So this maneuver is performed in case of a uterine inversion. And what is the name of this maneuver? So this is called as Johnson's maneuver. Okay, and what is the principle of this Johnson's maneuver? That the part which comes down first will go last. Part which comes down first, part which comes down first will go last. Will go last. Okay, and next to that we have one old method that we used to do, which was called as hydrostatic method. And this hydrostatic method, sir, it is outdated method now, and it was called as O'Sullivan method, and it was called as O'Sullivan method. And this O'Sullivan method, it is outdated method, and this O'Sullivan method, it is an outdated method. Now if followed by that the uterus is not possible to repose it, we relax the uterus, and to relax the uterus we give the drugs like a terbutaline. We give the drugs like terbutaline and nitroglycerin. We give the drugs like terbutaline and nitroglycerin. Okay, followed by that then we reposit the uterus and then give oxytocin to stop the bleeding. Okay, oxytocin and methogen. Okay, before you will give that terbutaline and nitroglycerin. But once it's relaxed, you reposit it, then stop the terbutaline and nitroglycerin, and then you can give oxytocin and methogen. Then you can give oxytocin and methogen. Okay, and if above methods are failed, then surgically you push the uterus back. And what are these surgical procedures we have? That is Huntington's procedure. That is Huntington's procedure. And so we have Haltian procedure. We have Huntington procedure and we have a Haltian procedure. So that's about the uterine inversion. That's about the uterine inversion. Now if you have a next question, answer me this faster. What is the initial management? What is the initial management for the uterine inversion? What is the initial management for the uterine inversion? What is the initial management for the uterine inversion? Write down in the chat box. You have a patient of a uterine inversion. What is the initial step? The first is always resuscitation. But if the resuscitation is not in the option, then your answer is going to be, it is again the previous year question, guys. So we have a manual reposition of the uterus. We have the manual reposition of the uterus, and that is what you call Johnson's maneuver. That's what you call Johnson's maneuver. Is that clear? Rest administration of the oxytocin. Later on you can go with that. Immediate hysterectomy. Okay, inversion, no need of hysterectomy unless there is an adherent placenta pargrata. Then you might can go for what? The immediate hysterectomy. Okay, if there is a pargrata, but that will be considered as a management for a adherent placentas, not for the inversion. Clear? Now next to that, a 40-year-old infertile woman suspected to be suffering from endometriosis. Now you have a 40 years infertile woman. She's a case of an endometriosis, is subject to diagnose the laparoscopy finding indicate uterus is normal. On the laparoscopy we saw that uterus is normal. Both the ovaries show the presence of chocolate cyst. Endometriotic deposits are seen on the round ligament right side. Both the fallopian tubes and the pouch of Douglas. Moderately dense adhesions are present between the fallopian tubes and the pouch of Douglas. The treatment of choices. So basically, in simple manner, there is a patient of endometriosis, but on the laparoscopy we saw that the uterus was normal. Both the ovaries shows that there was a chocolate cyst present, and we have these endometric deposits or these powdered bone lesions on the round ligament right side. Both the fallopian tubes we have these deposits, and these deposits are present over the pouch of Douglas as well. There are moderately dense adhesions present between the fallopian tubes and the pouch of Douglas as well. What is going to be the treatment of choice? So write down the answer in the chat box. So for the endometriosis, what will be the treatment here? Should we go for total hysterectomy with the bilateral salpingo-oophorectomy? Should we give a danazol? Should we go for a progesterone? Or should we go for the fulguration of these endometriotic deposits? Now, all these are the answers, right? All these are the treatment for an endometriosis. But in this scenario, what is going to be the best answer? Anybody in the chat box? What is going to be the best answer in this scenario? Yes. What is going to be the best answer? Very good. So, danazol is used as well, but here danazol will not be used because danazol is mainly used for the atrophy of the endometrium. Total hysterectomy, not at all, because she's an infertile woman and there is nothing wrong with the uterus. Uterus is normal, right? Progesterone, yes sir, it is given, but in this case the main treatment is going to be for the endometriotic deposits. That's what you call powder burn lesions or gunshot lesions, and for that treatment is going to be the fulguration of these deposits. So treatment is going to be the fulguration of endometriotic deposits. Okay, now let's understand what exactly is this endometriosis in a very short manner. What exactly is this endometriosis in a very short manner? Now it simply means that endometrial tissue is present somewhere else. Are you getting my point? So sir, it means occurrence of ectopic endometrial tissue. It means occurrence of ectopic endometrial tissue. Now, if we talk about the reason for this endometriosis, we had a lot of theories, but the most accepted theory related to this endometriosis was the Sampson's theory. And Sampson's theory says that the reason for this endometriosis is going to be the retrograde menses. That means the backflow of the menses. And usually 50% of females do have this retrograde menses, but the females having the low immunity will develop the endometriosis. They are going to develop endometriosis. Now the classical presentation of these patients, first of all, remember the age of the patient. They usually come with the age group around 25 to 35 years. The age group is around 25 to 35 years, and the investigation of choice for endometriosis is going to be laparoscopy. The investigation of choice is going to be laparoscopy, but the gold standard will be histopathological examination. The most common site is going to be ovaries, okay, but the second most common site, that is pouch of Douglas. The second most common site, that is going to be pouch of Douglas, and the least common site, that is going to be spleen and CNS. The least common is spleen and CNS. Now the question that the examiner can ask is, what will be the laparoscopic findings of these patients having the endometriosis? So number first one will be the given picture here. You can see that this is going to be the old blood accumulated in the cyst form, that is called as chocolate cyst of the ovary. Now this picture over here, guys, what is this picture? The laparoscopic findings, which is called as chocolate cyst of the ovary. Okay, now other findings we have these powdered burn lesions. We have these powdered burn lesions seen on laparoscopy as well, also called as gunshot lesions. Or we have these adhesions. We have these adhesions present as well. So we have these adhesions and fibrosis seen on the laparoscopy as well. So what are the classical findings of these patients? So number first very thing, so we have the adhesions, we have the chocolate cyst of the ovary, we have the powdered burn lesions or the gunshot lesions, and also on the laparoscopy we'll see that there is a thickening of this uterosacral ligament, which is a support of the uterus. So nodularity of this uterosacral ligament is also seen on the laparoscopy. So if the examiner will mention the clinical case and he mentions any of these findings, think of a endometriosis. Think of a endometriosis. So what will be the findings? So number first very thing, so the pathological or the laparoscopic findings of these patients is going to be number first one, chocolate cyst of the ovary. That is going to be chocolate cyst of the ovary. Number second, so we have the powdered burn lesions, or we have these gunshot lesions. Number third, so there will be the uterosacral ligament nodularity. What does that mean? Thickening of this uterosacral ligament. Okay, and there will be adhesions as well. And there will be adhesions and fibrosis. Okay, now next to that, what will be the classical symptoms of these patients? First of all, there will be a painful menses. That is going to be most common symptom. First of all, there will be a dysmenorrhea. And which type of dysmenorrhea it will be? So it's going to be a secondary dysmenorrhea. Why secondary dysmenorrhea? Because secondary dysmenorrhea is associated with some pelvic pathologies like PID, fibroid, and endometriosis. Next to that, this patients will have a painful intercourse. That is going to be dyspareunia. Other than that, patient will have infertility as well, and patient is having menorrhagia as well. That is heavy bleeding. Patient is having menorrhagia as well. So what are the symptoms? Patient is having dysmenorrhea, patient is having dyspareunia, patient is having infertility, and patient is having menorrhagia. So dyspareunia, dysmenorrhea, and infertility, this is called as classical triad of endometriosis as well. Now what will be the management? FASTME. So management, first of all, we have to manage the patient as the patient is having a mild or the moderate pain first. If there is a minimal or a mild pain, we start with the OCPs. But if a patient want to conceive, we go with NSAIDs. If the patient want to conceive, we go with NSAIDs. Okay, next to that, sir, the second line drug, we can give a progesterone. Second line drug, we can give this progesterone. Now this progesterone you can give orally, you can give injectable, or you can give a Mirena, which is an intrauterine contraceptive device, third generation, containing the levonorgestrel, which is further a second generation progesterone. Now sir, injectable, what injectable we use? So we can use the injection DMPA, that is depot medroxyprogesterone acetate. Okay, now this DMPA we can use 150 mg, and once every 3 months. We can use this once every 3 months. And this injection, this depot medroxyprogesterone acetate, is the same injection that we use is Antara, okay, which comes as a contraception. Okay, and the side effects of this depot medroxyprogesterone acetate is irregular cycles. Okay, but now here, what is the action, what is the aim to use this DMPA? So this DMPA will lead to atrophy of endometrium. ये क्या कराएगा? It will cause atrophy of endometrium. It will cause atrophy of endometrium. Now, what is going to be the third line drug? Further, so if the above two drugs, the third line drug we can give is a continuous GnRH analogs. The third line we can use is continuous GnRH analogs. Okay, that is goserelin, nafarelin, and all. Okay, now if above three failed, then next is going to be laparoscopy. Now if above three failed, Next is going to be laparoscopy. So remember, laparoscopy is both diagnostic as well as therapeutic. Laparoscopy is both diagnostic as well as therapeutic. Okay. Now further, now if a patient is having mild to moderate pain, now if a patient is having mild to moderate, or sorry, moderate to severe endometriosis, now then the first line drug is going to be GnRH analogs. Then the first line drug is going to be GnRH analogs, and the second line will be laparoscopy. Then the second line will be laparoscopy. Okay, and so what are the other drugs that can be used? Now the other drugs for the endometriosis, which will cause the faster atrophy of the endometrium as they have having an anti-estrogenic action, the drug is going to be a danazol. So danazol is having anti-estrogenic action. The danazol is having anti-estrogenic action. Okay, and as you know that estrogen is responsible for this proliferation of the endometrium. So when the drug danazol is given, it will cause a hypoestrogenic state and it will cause an atrophy of the endometrium. So what will it will cause? Atrophy of endometrium. But we have a side effects. We have the side effect of this danazol. That danazol will lead to the hirsutism. This danazol will lead to the hirsutism and virilization. Now what exactly is this virilization? So virilization means there will be breast atrophy, followed by that there is clitomegaly, and there is hoarseness of voice. And if you see that there is a change in voice, stop the drug. And if you see there is change in voice, stop the drug. So that is all about the medical management of endometriosis. So make sure you remember that endometriosis is more about a medical management, while as adenomyosis, that means when an endometrial tissue is present inside the myometrium, that is going to be adenomyosis, that is more of a surgical management, because the age group for the adenomyosis is 40 to 45, family is complete, and the definitive management for that is going to be hysterectomy. But in endometriosis, no hysterectomy I have mentioned, so don't mark answer as a hysterectomy. Now sir, what will be this laparoscopic management? Now for the recurrent chocolate cyst, or for the chocolate cyst, if the size of this cyst is less than 5 centimeters, what is going to be the management? So for that we'll follow up. For that we will follow up with USG. So if the size is less than 5 centimeter, we'll follow up with USG, and we can go for cyst aspiration. But in case the size is more than 5 centimeters, you have to go with a cystectomy. If the size is more than that, you have to go with a cystectomy. And to prevent the recurrence of this chocolate cyst also, you will go with cystectomy. So recurrent chocolate cyst, irrespective of the size, cystectomy. This has been the question asked back in 2023 June exams, that recurrent chocolate cyst, what is the best treatment? That is cystectomy. If the size is less than 5 centimeter, you go with the cyst aspiration and follow up with the USG. For these endometriotic deposits, as we have mentioned in the answer only, for these deposits we go for fulguration and cauterization. We'll do fulguration and cauterization. So these additions that are same will go for adhesiolysis. So that is all about the treatment for endometriosis. Number first very thing, remember, for adhesions we go for adhesiolysis. For these powdered burn lesions or the gunshot lesions, we go with a fulguration or the cauterization. If the chocolate cyst is mentioned, we go with the cystectomy if the size is more than 5 centimeter or recurrent cyst. But if the size is less than 5 centimeter, you have to go with a cyst aspiration. Clear to everybody? Yes. Now, sir, about an adenoma, it was endometriosis. About the adenomyosis, remember that patient is having menorrhagia, patient is having dysmenorrhea, and the question will mention about adenomyosis. Please remember that about the adenomyosis. About the adenomyosis, the patient will mention, examiner will mention that there is a symmetrical enlarged uterus. There is an enlarged uterus or uniform enlarged uterus, which is called as Halban sign as well. There is a uniform enlarged uterus, okay, with dysmenorrhea and menorrhagia. DNM. What is DNM? I will write full form, otherwise you're gonna make some new words. Patient is having dysmenorrhea. Patient is having excessive bleeding. Okay, that is going to be the case of adenomyosis. Remember that if there is a non-uniform enlargement of uterus, answer goes to the fibroid. If there is a uniform enlargement uterus with dysmenorrhea and menorrhagia, answer goes with the adenomyosis. And the definitive treatment for this adenomyosis, that is going to be the hysterectomy. What simply is this adenomyosis? It means when the endometrial tissue is present inside the uterus. Okay, that's why it is also called as endometriosis interna. क्या बोलते हो? It is also called as endometriosis interna. Endometriosis interna. Clear to everybody? Yes. So that's all about the endometriosis. Okay. I'm sure that whatever topics we are discussing in a detail, whatever question will come, you should be able to solve those questions. Okay, this is not a superficial revision. I'm going to the every bit of this topic, so make sure you interact more, you listen carefully, and you follow the same thing. Next to that, what is the next question given? A 30-year-old woman who presented with a secondary dysmenorrhea. As I mentioned already, secondary dysmenorrhea is the pain that will last even after the menses, and this will be pain present prior to the menses 3 to 4 days. And this secondary dysmenorrhea, it is related to the pelvic pathologies like PID and endometriosis. Now, this lady has been diagnosed with what? Endometriosis. As mentioned earlier, that secondary dysmenorrhea is related to the pelvic pathology. Now, sir, which of the following drug is not used in this patient? So, which of the following drug you will not give in this patient? Very easy question, guys. Which of the following drug you will not use in this patient? Which of the following drug you will not use in this patient? Which of the following drug you will not use in this patient? Which of the following drug you will not use in this patient? So progesterone, yes, we have used progesterone in the form of injection. DMPA, sir, danazol, yes, danazol is having anti-estrogenic action. It will lead to the atrophy of the endometrium faster. GnRH analogs, yes, we give in a continuous form. GnRH analogs, they will lead to the down regulation of the pituitary, decreasing the FSHLH, which will further decrease this estrogen. So estrogen, no, guys, we have to use anti-estrogen. Estrogen is not used. Estrogen is not used. Estrogen is not used. Clear to everybody? Clear to everyone? Can we move to the next question? Okay. A 35-year-old gravida 4 para 3 woman with a history of 3 previous cesarean deliveries is found to have an anterior placenta previa on routine ultrasound at 28 weeks of gestation. So a lady with a history of previous cesarean deliveries, and she's having now anterior placenta previa, that means placenta in the lower uterine segment, at 28 weeks of gestation. So I will mention one more question over here. If a patient is coming to you around 26 weeks with the low-lying placenta, that means placenta is in the lower uterine segment, okay, what is your next step? This has been the previous year question asked. So next step is that we perform again the USG at 32 weeks, because up till 32 weeks the placenta from the lower uterine segment, it can go to the upper uterine segment, and we call it as a placental migration. क्या बोलते हैं इसको? Placental migration. And कब तक होता है? It is till 32 weeks. Please do remember, this has been the question asked. So if after 28 weeks, do not mark as an expected management. First, repeat the USG at 32 weeks. So this 28 weeks of gestation, we saw that lady coming with the 3 previous cesarean deliveries, she's having now placenta previa at 28 weeks. The Doppler suggested that there is an abnormal placental attachment with a loss of retroplacental hypoechoic zone, and these placenta is invading now, and it's appearing to invade the bladder wall. What is the most likely diagnosis? Now this is a case of a placenta accreta spectrum, okay, or this is a case of a adherent placenta. Now what exactly is this adherent placenta? Let's understand first. Now sir, when we talk about the placenta accreta spectrum, okay, or this is also called as placenta accreta syndrome, this is also called as placenta accreta syndrome. Now sir, what happens in this placenta accreta spectrum? The placenta is firmly adherent the placenta is firmly adherent to uterine wall. Placenta is firmly adherent to uterine wall, and this firm adherent to the uterine wall, it is due to the absence of decidua basalis. It's due to the absence of decidua basalis, or the fibrinoid layer, which is called as neta bush layer, or the fibrinoid layer, which is called as a neta bush layer. Neta bush layer. Now, depending upon the degree of invasion of this placenta inside the myometrium or apart from the myometrium, we have 3 types. Okay, that is going to be normal. First one, this is a normal placenta. Then we have A, I, and P. That is accreta, increta, and parcreta. What is AIP? Accreta, increta, and parcreta. A, this is attached to myometrium. I, this is invading the myometrium. Okay. P, this is going till pelvic structures. This is going till pelvic structures. So what are the 3 types? Increta, accreta, and parcreta. How do you remember these 3? AIP. Now, my dear students, what is placenta accreta? So it means the placenta, it is attached to myometrium. It is attached to myometrium. Number 2, we have increta. It invades the myometrium. It invades the myometrium. Number 3, placenta parcreta. So it invades through serosa. And it is going till pelvic structures. And it's going till pelvic structures. And the most common pelvic structure that is involved in placenta parcreta is gonna be bladder. Okay, so this question simply mentions that there is this badly adherent placenta, and this goes, it invades the bladder, it invades up to the bladder wall. So this is going to be a which type of the adherent placenta? This is a placenta parcreta. This is going to be the placenta parcreta. This is going to be the placenta parcreta. Okay. Now, next to that, what will be the investigation for these patients? So we will go with USG, Doppler, USG with Doppler, and also best will be MRI to know the exact invasion of this placenta. We go with the USG Doppler as well to know the blood supply as well. And the management for this, if it is a parcreta, we go with obstetric hysterectomy. We go with obstetric hysterectomy. That's all about the placenta accreta spectrum. Now, sir, tell me which of these placental implantations would most likely cause excessive bleeding? Now, among these accreta, increta, and parcreta, which one will lead to the excessive bleeding? Which one will lead to the excessive bleeding? Which one will lead to the excessive bleeding? If you have increta, accreta, and parcreta, which one will lead to the excessive bleeding? Yes, so the one which is invading up to the pelvic structures, that is going to be increta and parcreta. So parcreta will be having more complications, as we have discussed that which among the following will have the excessive complications. That is going to be the parcreta. And parcreta, this adherent placentas, they are also responsible for the uterine inversion. They are also responsible for uterine inversion. Now, next to that, one of the very important questions that will be asked. Now, a woman who is 6 weeks pregnant, present to your clinic with the concerns about the medications. She's taking isotretinoin for the acne. Okay, drug of choice for acne is retinoic acid as well. What is the most likely teratogenic effect associated with this drug, bache? Now tell me, you have a patient, okay, and she has conceived. Now the question is, among which of the following is the side effect or the teratogenic effect associated with the drug, that is isotretinoin? Okay, now write down in the chat box what will be the answer. Among which of the following is a drug that is associated, among which of the following teratogenic effect is associated with a drug isotretinoin? Which of the following side effects is associated with isotretinoin? Very good. So renal agenesis, no, renal agenesis is associated with AC inhibitors. Okay. Neural tube defects, they are associated with decreased folic acid. This is associated with ACE inhibitors. Cardiac anomalies is associated with a lithium, which leads to Epstein anomaly. The answer is going to be craniofacial abnormalities. The answer is going to be craniofacial abnormalities. Now let's discuss about these teratogens. This is going to be an important question in your exams as well. Now about these teratogens, the first one is anti-epileptic drugs. If we talk about the safest anti-epileptic drugs, we have lamotrigine and levetiracetam. But anti-epileptic drugs like phenytoin and valproate, if given in the pregnancy, they will lead to the fetal Huntington syndrome. They will lead to the fetal Huntington syndrome. And in fetal Huntington syndrome, the patient is going to have an upturned nose. The baby is having, the feature is upturned nose. Okay. Next one, so AC inhibitors and ARBs. If a patient is taking AC inhibitors, prils and statins, what will happen? There will be a decreased blood supply to the kidneys, which will further lead to the oligohydramnios. So we call it as fetal renal hypoperfusion. There is fetal renal hypoperfusion. That is decreased blood supply to the kidneys. Decreased blood supply to kidneys. Next to that, if a patient is taking alcohol, there will be a brain abnormality to the fetus, and the syndrome is fetal alcohol syndrome, and the syndrome is fetal alcohol syndrome. Okay, and the patient will have the brain abnormality. The patient will have, the baby will have the brain abnormality. Okay, all these effects are going to be to the fetus only. Now, if the patient is taking lithium, what will be the teratogenic effect? Baby will have Epstein anomaly. And Epstein anomaly is associated with which type of heart? And a box-shaped heart. Box-shaped heart. Okay, and lithium side effect is always gonna be a very important question for the examiners. So lithium side effects, remember here only, so lithium side effects Remember LITTH. Okay, L is leukocytosis, I is insipidus diabetes, that means it causes diabetes insipidus as well. T is teratogenic, causes abstinence anomaly. One more T, that's going to be most common side effect, tremors, and H is hypothyroidism. This has been a question asked, which among the following is not a side effect of the lithium? So remember, these are the five main side effects: leukocytosis, diabetes insipidus. Okay, remember diabetes insipidus have three reasons: either nephrogenic, either neurogenic, central, or either drug induced. If drug induced has been asked, that lithium is a drug that causes this diabetes insipidus, the answer for that treatment is amiloride. So lithium induced diabetes insipidus, the answer is treatment for that drug of choice is amiloride. Central, desmopressin, nephro, that is Hyzax. You already know that. So but do remember about the lithium side effect as well. This has been the question asked multiple times. Okay, now next to that, indomethacin, so it will cause premature closure of ductus arteriosus. So it causes premature closure of ductus arteriosus. Okay, and to maintain the patency, which drug we give? Which drug we give in order to maintain the patency of ductus arteriosus? So we give a prostaglandin, that is going to be L-prostadil. That is going to be L-prostadil. Next to that, methimazole. So it is used in the second and third trimester for the hyperthyroidism, because if we use this drug in the first trimester, it will cause aplasia cutis. It will lead to the aplasia cutis. And aplasia cutis means there is absence of dermis and epidermis. Absence of dermis and epidermis. Okay, next to that, warfarin. Warfarin will lead to the warfarin embryopathy. Warfarin will lead to the warfarin embryopathy. Okay, next to that, thalidomide, it will lead to the phocomelia, abnormal limbs. Okay, phocomelia. Methotrexate, it will lead to the clover leaf skull, that these sutures in joints will fuse earlier. We call it as craniosynostosis. Clover leaf skull, that is craniosynostosis. Process. Next to that, if we talk about paroxetine, it will lead to the pulmonary hypertension. Paroxetine, it will lead to the pulmonary hypertension. And the last one, erythromycin, it will lead to the congenital hypertrophic pyloric stenosis, CHPS. And mifepristone, it will lead to the Mobius syndrome. It will lead to the Mobius syndrome. So these are all the teratogenic effects of the following drugs. So remember, anti-epileptics will lead to the fetal head and twine syndrome. We have the AC inhibitors and the ARBs. They will lead to the fetal renal hypoperfusion. When there is a decreased blood supply to the kidneys, the baby will have a decreased GFR. The baby will have a decreased urine formation. As we know that this urine is a main contributor of the amniotic fluid post 20 weeks, then eventually the baby is going to have oligohydramnios. So eventually, what will be the complication? Mother will have oligohydramnios. Alcohol will lead to the fetal alcohol syndrome. Lithium will lead to the Epstein anomaly. And indomethacin will lead to the premature closure of the ductus arteriosus. Methimazole, aplasia cutis, that is absence of dermis and epidermis. Warfarin will lead to the warfarin embryopathy. Thalidomide will lead to the phocomelia. Methotrexate, clover leaf skull or the craniosynostosis. Paroxetine, pulmonary hypertension. Erythromycin, CHPS, and mifepristone will lead to the Mobius syndrome. So that's all about the teratogenic effects of these drugs. Okay, next to that, what will be the answer for this particular question, guys? Tell me, what will be the answer for this particular question? A pregnant woman with a hypertension is currently taking an AC inhibitor. What fetal complication is most associated with AC inhibitors in the pregnancy? So what will be the answer for this particular question? What will be the answer for this particular question? Write down in the chat box, everybody. Yes. Yes, speed is okay. I am going fast as this is a rapid revision session, but I'll make sure that whatever discussion, whatever topic we are discussing, we should get that particular topic in exams for sure. The aim is to cover everything that have been asked, not in a superficial manner. So what is going to be the answer for this particular question, guys? Very good. So the answer for this is it will cause renal dysgenesis and oligohydramnios. Renal dysgenesis and oligohydramnios. First one, cardiac malformation associated with lithium, limb deformities associated with phocomelia, neural tube defect associated with vitamin B9. So the answer for this is renal dysgenesis or agenesis with oligohydramnios. Next to that, the next question. A 20-year-old girl presents to you with the cramping abdominal pain. So a lady is coming with the cramping abdominal pain. It starts at the onset of menses and it's more pronounced on the first day. So the female is complaining of a cramping abdominal pain, and this pain usually starts at the time of menses and it's more on the first day of the cycle. And the pain started around 15 years of age. That means once the menarche starts, once the cycle begins and she's having that pain. Okay, it is not that she's having this pain from the 15 years of age. No, it is just that when the cycle started, and then every prior to the cycle, on the day of the cycle, every time she's feeling this pain, and it is more on the first very day. Which condition is she likely to be suffering from? Okay, now you already know pain during the menses is what? Dysmenorrhea. Pain during the menses is dysmenorrhea. Now this dysmenorrhea can be either primary or this dysmenorrhea can be either secondary. Now when I talk about this primary dysmenorrhea, it is due to the prostaglandin release. And when I talk about the secondary dysmenorrhea, it is a pain which is related to the pelvic pathology. When we talk about this primary dysmenorrhea, it is a pain which is seen on the first very day of the cycle and it will remain just 10 hours post cycle or 1 day. Later on it will subside or minimize. But when we talk about this dysmenorrhea, the pain will start prior to the cycle, 2 to 3 days before the cycle, and it will last throughout the cycle and it will remain even few days after the cycle as well. So that is going to be a secondary dysmenorrhea, which is also called as congestive dysmenorrhea, and primary it is also called as spasmodic dysmenorrhea. So let's understand the different types of pain during the menses. Now first very is what is dysmenorrhea. So dysmenorrhea, so simple words, it is pain during the menses. That is pain during menses. Dysmenorrhea is pain during the menses. Now what is primary dysmenorrhea? So pain starts on first day, number first thing, then followed by that pain due to prostaglandins, and which one mainly PGF2 alpha release, and it is not pathological. It is not pathological. That is about a primary dysmenorrhea or a spasmodic dysmenorrhea. What is secondary dysmenorrhea or congestive dysmenorrhea? Pain starts 3 days prior to cycle. Pain starts 3 days prior to cycle and remains throughout the cycle. And remains throughout the cycle, and followed by that it is related to pelvic pathology. The pain is related to pelvic pathology, like it is related to the PID, it is related to the endometriosis. It is related to the endometriosis, right? So that is going to be a secondary dysmenorrhea. Now primary is not pathological, normally prostaglandin release हो रहा है. Secondary, it is a congestive dysmenorrhea and it is related to the pelvic pathology. Okay, and then we have a membranous dysmenorrhea. Now inside the uterus we have a fibrinolytic system which prevents the clumping or the clotting of the blood. Now if this fibrinolytic system is absent in the uterus, there will be more clotting and the clumping of this blood. Okay, now in order to pass these clots we need more contractions. So more the uterus will contract, the cervix will dilate and this clot will pass. So the more contractions will lead to the more pain, and such a pain is called as a membranous dysmenorrhea. Very simple thing, guys. So we have fibrinolytic system in uterus which is responsible for less clumping of blood. Which is responsible for less clumping of blood. If absent, more clots, which will lead to more pain, and such a pain is called as a membranous dysmenorrhea. So we'll write here more clots, more contractions, and more pain, and such a pain is called as a membranous dysmenorrhea. Such a pain is called as a membranous dysmenorrhea. Is that clear? So that is primary dysmenorrhea, secondary dysmenorrhea, and a membranous dysmenorrhea. Next question. A 28-year-old woman reports experiencing sharp localized lower abdominal pain that occurs consistently midway through her menstrual cycle. The pain resolves within a few hours. She has no other symptoms. What is the most likely diagnosis? Okay, now this classical hint that is mentioned, that this pain occurs midway through her menstrual cycle. That means this is a mid-cycle pain. Okay, so what will be the answer for this particular question? Very good. So it is called as mid-cycle pain, or the ovulation pain, or Mitchell-Marsh pain. Okay, and this pain is, it is pain during the ovulation. It is pain during the ovulation. So what exactly happens? This debris or the blood, it gets accumulated in the pouch of Douglas, which leads to the pain during the ovulation. Such a pain is called as a Mitchell-Marsh pain. Such a pain is called as a Mitchell-Marsh pain. Clear? Now next question is that which of the following next question is that which of the following complication is unlikely in a patient with a gestational diabetes? Now, as we have discussed in our main notes as well about a gestational diabetes mellitus, one of the important chapters. Now sir, among which of the following complication you will less likely see with a GDM? You will less likely see with a GDM. Yes, write down in the chat box what can be the answer for this particular question. Now among which of the following you will see, among which of the following you will less likely see with the GDM. Very good. So abortion will be there. Yes, abortion is related to that. Macrosomic baby, yes, insulin acts as a growth factor which increase the size of the baby. Postpartum hemorrhage, yes, as this macrosomic baby will have a big baby which will lead to the over distension of the uterus. Further, the tone of the uterus is decreased, and we have discussed that whenever there is an atonic uterus, it will lead to the postpartum hemorrhage. So what is going to be the answer? So GDM is not associated with oligohydramnios. GDM is not associated with oligohydramnios. Rather, it is associated with a polyhydramnios. Okay, rather it's associated with the polyhydramnios. Now, what exactly is a gestational diabetes mellitus? So it occurs around how many weeks onwards? It occurs around 24 weeks or beyond. It occurs around how many weeks beyond? It occurs around 24 weeks or beyond. Now, there are two hormones which are responsible for this GDM. The two hormones are, we have human placental lactogen, and mainly we have estrogen. Now these two hormones, they have an insulinase like action. Okay, so these two hormones, they are going to induce the insulin resistance. These two hormones, they are going to induce insulin resistance. And once this insulin resistance is induced, what will happen? So there will be increase in the blood sugar levels, and there will be increase in the blood sugar levels. Okay, so these two hormones, what are the hormones which are responsible for the gestational diabetes mellitus? That is HPL and estrogen, because they have a insulinase like action. They induce the insulin resistance, and eventually there will be increase in the blood sugar levels. Now if a patient is having pre-existing increased sugar levels, if the patient is already diabetic and patient conceived, at that time I will call it as an overt diabetes mellitus. At that time I will call it as an overt diabetes mellitus, or I will call it as a pre-gestational diabetes. I will call it as overt diabetes, or I will call it as a pre-gestational diabetes. Now, my dear students, you tell me that which one among the following will be associated with the congenital anomalies? Is this a over diabetes which will be associated with the congenital anomalies, or it is an over diabetes or a pre-gestational diabetes? So it is gonna be a over diabetes or a pre-gestational diabetes. Why? Because GDM occurs 24 weeks onwards. GDM occurs 24 weeks onwards, and till then organogenesis already happened. Now, sir, screening for the over diabetes. Now, what will be the screening test for the over diabetes? So we go with a fasting blood sugar. We go with a fasting blood sugar. We can go with a random blood sugar, and we go with HbA1c. We go with HbA1c. And remember, NEET PG PYQ was asked, RBS should be how much? More than 200 grams per deciliter. HbA1c should be more than 6.5. At that time, you can write that yes, this is a perfect case of a this is a classical case for a gestational diabetes, overt diabetes mellitus. Okay, now next to that, what will be the test for a gestational diabetes? Now around 24 weeks, we will check that first fasting blood should be less than 92, then it is normal. Okay, then we go with the oral glucose tolerance test, that is OGTT, and this OGTT will give the 75 grams of sugar. Okay, and this 75 grams of sugar, after that you will check the blood sugar levels at 1 hour and 2 hour. So fasting it should be less than 92. Okay, 1 hour it should be less than 180, and 2 hour it should be less than 153. And remember that this test is called as a one-step test. क्या बोलते हैं इस टेस्ट को बच्चे? So this test is called as a one-step test. Okay, now any one of the abnormal value, what does the abnormal value mean here? Any one of the abnormal value, if in case it is mentioned more than 92 होगा sugar levels, अगर sugar levels more than 180 होगा after 1 hour, or at 2 hours it will be more than 153. That means this is a classical case of a confirmatory case of a GDM. So any one abnormal value is diagnosis of GDM. Any one abnormal value, it is going to be diagnosis of GDM. Now, sir, as we know that GDM will have a macrosomic baby eventually, because the insulin acts as a growth factor. Now, rather going in a detail, tell me what will be the effects on the mother. So what will be the effects on the mother? First of all, if the baby is bigger, there are increased chances of cesarean section. If the baby is bigger, there are increased chances of a cesarean section. Number first very good thing, if the baby is bigger, there are increased chances of postpartum hemorrhage. On baby, if I talk about the side effect, baby, there will be difficulty in the delivery of the shoulder. So on baby, the effect will be, there can be a shoulder dystocia, and this effect is on baby. Remember, and followed by that there are increased chances of the birth canal injuries. There will be birth canal injuries. Now students, tell me that what exactly is the shoulder dystocia? The timeline has been asked that shoulder dystocia means that if there is a delay in the delivery of the shoulder by more than 1 minute within the delivery of the head, by more than 1 minute, sorry, after the delivery of the head, we call it as a shoulder dystocia. Again, I'll repeat. So there is a delay in the delivery of the shoulder after delivery of the head by 1 minute. I call it as a shoulder dystocia, right? And the maneuver that we perform for the shoulder dystocia, that is going to be a main maneuver, that is going to be a Mac-Roberts maneuver. That is going to be a Mac-Roberts maneuver. Then you remember all other things that we have discussed. First of all, we'll call for help, then we'll evaluate for the episiotomy. Then we're going to do, in this picture you can see that the Mac-Roberts maneuver, there is a hyperflexion of the legs, so that the legs will be flexed into the abdomen, which will lead to the rotation of the pelvis, alignment of the sacrum, and it will widen it, opening of the birth canal. And then you apply the suprapubic pressure applied to the fetal anterior shoulder. Okay, now the question that can be here, what is the most common injury in the baby? The most common injury in the baby, that is going to be a Erb's palsy. Okay, so let's write these three things. Most common injury in the baby, most common injury in baby will have Erb's palsy. Erb's palsy. If Erb's palsy is not in the option, they can mention brachial plexus injury. If integrated way nerve root of Erb's palsy, they can mention C5, C6. Okay, right? What will be the most common complication on the maternal side? It will lead to the postpartum hemorrhage. Maternal complication, postpartum hemorrhage. Okay, and prior to the Mac-Roberts maneuver, we will widen the birth canal with the help of a planned incision, which is called as episiotomy. Now what is episiotomy? So we cut the skin, followed by subcutaneous tissue, followed by superficial transverse perineal muscle, then deep transverse perineal muscles, then the muscle fibers of the bulbospongiasis and levator, then the transverse branch of the pudendal nerve, and then the posterior vaginal wall. Remember, what are the structures not resected during the episiotomy? Can be the question asked. Anal sphincter is not resected. Ischiococcygis or ischiocavernosus, it is not resected during the episiotomy. Do remember these questions, and do remember how to suture it back. Okay, mucosa, muscle, skin, MMS, right? This has been the NEET PG question as well related to the episiotomy. Okay, then midline and mediolateral, and which one is performed? Mediolateral. Why mediolateral is good? Because of the less wound extension. So episiotomy is clear here only. Okay, remember those different types of scissors, the curved scissors, which is called as episiotomy scissors. Okay, now next to that, so what is the most common nerve injured in mother? Most common nerve injured in mother, that is gonna be lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh. And most overall complication, that is going to be the postpartum hemorrhage. Now later on we have different maneuvers as well. Gaskin's maneuver, we have this Gaskin's maneuver, we have Woodcock screw maneuver, we have Zamanelli maneuver. There are all the other ways if in case the Mac-Roberts failed. So remember, main one, that is Mac-Roberts maneuver. And once this shoulder dystocia, once the head is delivered and a baby shoulders are not able to deliver, baby shoulders are still stuck inside, we have a classical sign, we call that a turtle sign. तो turtle sign कहाँ पे दिखती है? Shoulder dystocia में. Turtle sign कहाँ दिखती है? Shoulder dystocia में. So that's all about the complications. Now problems to the newborn will be, now in a fetal life, baby is a hypoglycemic, but in neonatal life, fetal life, baby will be hyperglycemic, but in neonatal life, baby is hypoglycemic. So one of the main questions that they will ask, that so what are the problems of the newborn due to the diabetes, the baby will have a hypoglycemia. But if a question mentions what is a fetal complication, in fetal life he will have a hyperglycemia. But once the baby is born, due to the hyperplasia of the beta cells of pancreas, what is the reason for this hypoglycemia? Due to the hyperplasia of beta cells of pancreas. Due to that reason, patient is going to have, baby is going to be hypoglycemic. Now, what are the other features? Baby will be having hypocalcemia. Okay, there is also polycythemia. And once the RBCs are more, they will break down more, and there will be hyperbilirubinemia. There will be hyperbilirubinemia and hypomagnesemia. These are all the findings. Do remember everything, because they can ask any question. It is not mandatory that you have solved hypoglycemia in all the questions. So they will ask only hypoglycemia. They can ask any of the above. And remember that if they mention fetal life, answer is hyperglycemia. Agar neonatal mention kya, high answer are gonna be the hypoglycemia. Okay. Do not rely on the PYQs. Rely on the PYTs. Are you getting my point? PYQs will give you the idea from what exactly they can ask the question, from what topic they can ask the question. So PYQ is the key to remember everything of that particular topic. Okay, that is why we are trying to reach out to all the things that have been that can be possibly asked. Okay, if superficial things you just want to read out the PYQs, that you can do anywhere. Yes. So next to that, anomalies in an overt or pre-existing diabetes. Now, what are the anomalies that are associated with the pre-existing diabetes or in overt diabetes? Number first, very one, the most common group of anomalies is going to be cardiac anomalies, followed by CNS anomalies. Now, the most common cardiac anomaly is going to be VSD. The most common is going to be VSD, but as VSD is not specific, the most specific is going to be transposition of great arteries, egg on string appearance, transposition of great arteries. Then what are the other ones we can see? We can see VSD as well. We can see patent ductus arteriosus with the GDM as well. Now, if I talk about the neural tube defects, we have multiple neural tube defects associated. We can have a spina bifida associated. We can have anencephaly associated. But the most specific is going to be the caudal regression syndrome. The most specific is going to be the caudal regression syndrome. Okay, which is also called as sacral agenesis. Which is also called as sacral agenesis. Okay, you can see there is abnormal development of these limbs. Answer, this is also known as sacral agenesis. That is most specific. Okay, most common we have cardiac defect, that is VSD. Now, for the also seen, what are the other neural tube defects also seen? We have spina bifida. We have a spina bifida, and we have one more, that is going to be anencephaly. That is anencephaly. Now, my dear students, if you remember that spina bifida, two signs were asked. What are the two signs in the spina bifida? We have a classical lemon sign and banana sign. What are the two signs which are seen? Lemon sign and banana sign. And what are the two signs seen in anencephaly? We have a frog eye sign and we have a Mickey Mouse sign. Anencephaly due to the failure of closure of anterior neuropone on day 25, and spina bifida on day 28. Remember that. And in order to prevent such neural tube defects, we see the marker. What is the marker? Acetylcholinesterase in amniotic fluid. Remember this as well. And in order to decrease the chances of neural tube defects, we start with the folic acid in the pregnancy. If a patient is having history of this neural tube defect, then 4000 micrograms per day. If not, 400 micrograms per day. And as per the Anemia Mukt Bharat, 500 micrograms per day. Okay, now the management, these things not to be written because you have already studied about these things. You have studied in PSM as well. So this is just a verbal revision for these things. Now, what is going to be the management for this particular condition? So we always, the first management is going to be, that is diet modification. The first management, that is going to be the diet modification. Now, if a patient is on the oral hypoglycemics and if the patient is over diabetic, shift on the insulin. And if drug of choice will be asked, that is going to be insulin. Which one? Regular. Okay. And oral hypoglycemics, we give a drug that is metformin, oral hypoglycemic drug. It belongs to the biguanide. Okay. And next one, that is glyburide, and it belongs to the which class? That is sulfonyl urease. That is sulfonyl urease. So that is all about the gestational diabetes mellitus. Okay, so do remember all the important points that I have mentioned. Now the next question asked is from the ectopic pregnancy. Now answer me the question, guys. A 28-year-old woman with the history of infertility, a 28-year-old woman with the history of infertility for 3 years presents with a 6 weeks amenorrhea. This lady presents with a 6 weeks amenorrhea. Okay, and she has a mild abdominal pain and spotting. She has a mild abdominal pain and spotting. Her UPT is vaguely positive, and on examination she is hemodynamically stable. There is a 3 into 2.5 centimeter left-sided adnexal lesions. The ultrasound revealed that there is a left-sided tubal gestational sac with no cardiac activity. That means there is a pregnancy inside the tube. So classical diagnosis of an ectopic pregnancy. Her beta HCG levels are 2500 international units, which is the best management option for this particular patient. So write down in the chat box, everybody. So what do you think is gonna be the best management of this patient? What's going to be the best management of this patient? So you have a patient coming to you. She had infertility for 3 years. Now she has a UPT which is weakly positive, and she's coming with a mild abdominal pain and the spotting. UPT is a weakly positive. She's hemodynamically stable. Okay, and there is a left-sided adnexal lesion. There is a left-sided adnexal lesion over there. And ultrasound confirmed that this is a left-sided tubal pregnancy with no cardiac activity. And beta HCG, you have 2500 international units. Now, what is your diagnosis, bache? Very good. Diagnosis itself says that this is the case of ectopic pregnancy. This is a case of ectopic pregnancy. Very good. Now, ectopic pregnancy, you know that whenever the presentation of patient is mentioned, you focus on the vitals first and the presentation first. Now, first of all, patient is not bleeding. She's just complaining of mild abdominal pain and spotting. And then next to that, patient is hemodynamically stable. And it is confirmed that there is a left-sided tubal pregnancy. So when we talk about ectopic pregnancy, either the ectopic pregnancy will be ruptured, or either this ectopic pregnancy will be unruptured. So what does rupture mean? The tube has been ruptured, the patient will heavily bleed, and the hemodynamically patient is going to be unstable, right? But comparatively to when you talk about unruptured, patient might bleed or might not bleed, and even if the patient bleed, it will bleed lesser, and so vitals will be usually stable. So this case, the patient is going to be an unruptured ectopic pregnancy. Now, what exactly is going to be the treatment? So you have a classical case with an unruptured ectopic pregnancy with the beta HCG 2500 international unit. What is going to be the best management? Sir, salpingotomy and gectomy we will not do. Why? Because the surgical procedures for unruptured one is a salpingotomy and gostomy, and gostomy and the milking of tube is only done when a patient is having the beta HCG more than 5000. Sir, salpingectomy, it is for the ruptured ectopic pregnancy. It is for the ruptured ectopic pregnancy. And salpingostomy and milking of tube, it is for a unruptured. But it is only the answer when this beta HCG would have been more than 5000. So what about salpingectomy? There is no need of a beta HCG levels or the ectopic mass. If the tube is ruptured, there is only one management, that is going to be a salpingectomy. So for this, we go with the medical management, that is injection methotrexate. So for this particular condition, what is the management? So less than 5000 beta HCG with a stable patient, unruptured ectopic pregnancy. The answer is going to be medical management, and the main drug is methotrexate. Now let's understand when to go for salpingotomy, ostomy, when to go for the hysterectomy, when to go for a medical management, and what exactly are the reasons behind this ectopic pregnancy. Now, first of all, what is an ectopic pregnancy? It simply means the pregnancy outside the uterus. What is ectopic pregnancy? So it is pregnancy outside uterus. Okay, remember, whenever a patient is complaining of a mild spotting, pain, or a bleeding around to 6 to 8 weeks, think of a what? Abortion and ectopic pregnancy. Think of a what? Abortion and ectopic pregnancy. And ectopic pregnancy by 6 to 8 weeks will be the question always framed, or 6 to 10 weeks, or 6 to 10 weeks. So any question complaining of a bleeding, or any question which starts with the 6 to 10 weeks, think of an ectopic pregnancy. Why? Because around 6 to 10 weeks we are expecting that for damn sure that pregnancy will go into the uterus. But if up till 10 weeks it is not going in the uterus, that means the pregnancy is outside the uterus, which means an ectopic pregnancy. Now if we talk about the most common site, okay, the most common site is gonna be a fallopian tube. Okay, most common site is gonna be a fallopian tube, and most common in fallopian tube, then that is gonna be a ampulla. Then further we have isthmus, interstitial, femoral, all other locations. Okay, so remember, most common is going to be fallopian tube, and most common in the fallopian tube is ampulla. Now, earliest to rupture, if you have a question, earliest to rupture in ectopic pregnancy, so which is earliest to rupture? Up to earliest to rupture, then it is going to be isthmus. Then earliest to rupture is going to be isthmus, and isthmus rupture around 4 to 6 weeks. Isthmus ruptures around 4 to 6 weeks. Number first thing. Number second, most common to rupture. So obviously if ampulla is the most common site, and then ampulla is the most common site to rupture as well, but earliest to rupture if mentioned, then it's going to be isthmus. Now the same ampulla question was asked, that this ampulla is going to be the most common site for genital tuberculosis. Question number 1 asked in your previous year question. This is the widest part of the fallopian tube, and then followed by that, this is the most common site for fertilization as well. Okay, now what is the most common cause for this ectopic pregnancy? That is going to be a pelvic inflammatory disease. That is going to be a pelvic inflammatory disease. And if the examiner mentions what's the most common risk factor associated, so risk factor is a previous ectopic pregnancy. Now next to that, now presentation of this patient, it comes with a classical triad of a pain, bleeding, and amenorrhea. Pain plus bleeding plus amenorrhea. Pain, bleeding, and amenorrhea. Now sir, we have a classical signs as well due to this ruptured ectopic pregnancy. Remember that it irritates the diaphragm due to the hemoperitoneum. We can have first 2 signs that is not fully specific to the ectopic pregnancy, because they can be present at acute pancreatitis as well. Now these signs are Cullen's sign and the Gray-Turner sign. Now what is Cullen's sign? It is bruising around the umbilicus, which is called as a Cullen's sign. And we have a bruising around the flanks, which is called as a Gray-Turner sign. क्या बोलते हैं इसको? Gray-Turner sign. So these signs are also seen in pancreatitis. Yes, and along with these signs, we have other signs in pancreatitis as well, like as ecchymosis in the inguinal region, ecchymosis around the scrotal region, Fox sign, Bryant sign. They are the other signs as well. Now these patients, when a patient is complaining of a heavy bleeding with the vitals unstable, would you think of a ruptured ectopic pregnancy or an unruptured ectopic pregnancy? We think of a ruptured ectopic pregnancy. And due to this hemoperitoneum, when the bleeding is too much, it irritates the diaphragm and it gives a referred pain to the shoulder tip, which is called as a Danforth sign. तो ये Danforth sign कहाँ दिखती है? Sir, this Danforth sign, this is seen in case of this shoulder tip pain. This is seen in case of a ruptured ectopic pregnancy. Shoulder tip pain due to the hemoperitoneum, which is called as Danforth sign. Okay, So anytime there is a hemoperitoneum, we have a Danforth sign, and anytime we have a splenic injury, we have a Care sign, right? So next to that, sir, in a ruptured ectopic pregnancy, what will be the treatment first? Now I have discussed that the most common cause is going to be PID, and most common site is going to be fallopian tube. Other than fallopian tube, it can be present in the cervix, it can be present in the abdomen, it can be present in the previous cesarean scar. And other than the pelvic inflammatory disease, what can be the other causes for that? It can be a genital tuberculosis, it can be a ectopia, it can be the use of IUCDs, it can be a pelvic infection, it can be any pelvic injuries, okay, it can be cervicitis, it can be IVF. All are the other causes for the ectopic pregnancy. Now sir, what will be the features if the patient is coming with the ruptured ectopic pregnancy? There will be shock and syncope. Now further that ruptured ectopic pregnancy mein, what will be the first management? So I will go with a resuscitation. I will go with a resuscitation. Followed by that, remember, secure the IV line, secure the IV line, and sir, arrange blood. Arrange the blood. And the surgery that you can go with is total salpingectomy. Now there is only one surgery that we do, that is total salpingectomy. Now sir, this total salpingectomy, it can be done by two ways. Either we can go for laparoscopy, or either we can go for laparotomy. So when I talk about laparoscopic salpingectomy, so we have two scenarios. So if vitals are stable, we go with either laparoscopic or laparotomy. That is when vitals are stable. But if vitals are not stable, then laparoscopy is contraindicated, because when we go for the laparoscopic procedures, we inflate with the carbon dioxide, and it will further decrease the cardiac output, and eventually it will worsen the symptoms of the shock. So it will furthermore cause a hypotension. So remember, if the vitals are stable in ruptured ectopic pregnancy, sir, we can go with the laparoscopic salpingectomy or laparoscopy. But if the vitals are not stable, you have to remember, you can only go with laparotomy, because laparoscopy is going to be contraindicated. Okay, now if a patient is having an unruptured ectopic pregnancy, okay, now unruptured ectopic pregnancy, we can have two management, okay, medical management and surgical management. But in case of a ruptured ectopic pregnancy, there is no role of beta HCG, there is no role of ectopic mass size. Now where exactly will this role play? That is in case of an unruptured ectopic pregnancy. Now if the size of an ectopic is more than 4 centimeter, you go with a surgical management, and if the size of an ectopic is less than 4 centimeter, you go with a medical management. If the beta HCG is more than 5,000 international units, you go with a surgical management. If the beta HCG is less than 5,000 international units, you go with a medical management. If the cardiac activity is present, you go with the surgical management. If the cardiac activity is absent, you go with a medical management. If the signs of rupture are present, you go with a surgical management. If the signs of rupture are absent, you go with a medical management. If a patient is hemodynamically unstable, you go with a surgical management. If the patient is hemodynamically stable, you go with a medical management. So that is all about medical management, factors, and the surgical management. So in this scenario, there was unruptured ectopic pregnancy with the beta HCG less than 5,000. Your answer is classically medical management, and the drug that we give is injection methotrexate. What is the drug? Injection methotrexate. Clear to everybody? Now next to that, what are the medical drugs that we use? We use a drug that is methotrexate. It is a DHFR, dihydrofolate reductase inhibitor. Methotrexate, we use mifepristone, which is an anti-progestin. We use mifepristone. Followed by that, we use KCL. We use prostaglandins. and we use actinomycin. That is all about the drugs medical management in ectopic pregnancy. And what are the surgical management? What exactly is the surgical management for an ectopic pregnancy which is unruptured? So first of all, in unruptured, we are trying to save the tube, right? So we have features. We have the salpingotomy. We go with linear salpingotomy. Then we have salpingostomy. We have resection anastomosis. And milking of tube. So these are all the ways we can go for surgical procedure. Then you already know the difference between gotomy and gostomy. In one, you mark the incision of the tube, you take out the ectopic and you close the tube. But when you go for salpingostomy, you do the incision on the tube, you take out the ectopic and you leave the tube open, and eventually this tube will heal by the secondary mechanisms. And then milking of tube, it is outdated now, but still I have mentioned in the options, because what if you get an option like this, you end up by marking the things that you have not found, right? So make sure to look for a beta HCG first. If the beta HCG is more than 5,000, you go with the surgical management. If it is less than 5,000, you go with the medical management. If the size of ectopic is more than 4 centimeter, you go with the surgical management. If it is less than 4 centimeter, you go with the medical management. If the cardiac activity is present, you go with a surgical management. If the cardiac activity is absent, you go with the medical management. Is that clear? Then we have some named criteria for the different types of ectopic. For the cervical, we have Rubin's criteria. For ovarian ectopic, we have Spielberg's criteria. For abdominal ectopic, we have a Study-Ford criteria. And for the previous cesarean scar, we have a Gordon's criteria. And NEET PG PYQ 2022 was asked that what is the name criteria for the ovarian ectopic pregnancy? Clear? So do remember about this as well. Now next to that, answer me this question now. That a 25-year-old primary gravida presents with the, everybody in the chat box, presents with the lower abdominal pain and heavy bleeding per vaginum. So yeah, lady with the abdominal pain and the bleeding per vaginum. On palpation, the tenderness is noted and the bruising is seen around the umbilicus. So this bruising around the umbilicus is which sign? Sir, it is going to be a Cullen sign. The further examination reveals that the blood pressure of the patient is 90/60. The heart rate is 110. UPT was positive and beta HCG was 1500 international units. So all these hints: heart rate 110, BP 90/60, UPT positive, beta HCG 1500. Now, what will be the USG performed? No double decidual sign. Now, this double decidual sign is an indicative of a intrauterine pregnancy. If a double decidual sign is present, it's a intrauterine. If it's absent, it's an ectopic. So there was no double decidual sign, but adnexal mass was noted. So it's a classical case of an ectopic pregnancy. Now tell me guys, what will be the most appropriate management? What will be the most appropriate management? Everyone in the chat box. What will be the most appropriate management in this condition? Yes. So you have a patient coming to you with a heavy bleeding. So patient is having a heavy bleeding, and that too shock-like features, 90/60. So this is a ruptured or unruptured? So this is a ruptured ectopic pregnancy. So I will go with a laparotomy plus total salpingectomy. I'll go with the laparotomy plus total salpingectomy. Is that clear to everybody? Yes. So what is going to be the answer for this particular question? What is going to be the answer for this particular question? We go with a total salpingectomy. Can we do the laparoscopy in this case? Everybody in the chat box. Can we do the laparoscopy in this case? No, sir. Laparoscopy is contraindicated as vitals are unstable. So that's all about the ectopic pregnancy. Okay. Now, next question. A 28-year-old gravida 3, para 1, at 33 weeks of gestation came to the clinic for a regular antenatal checkup. So gravida 3, she's third time pregnant, para 1, past the age of viable 28 weeks, and she has one abortion previous. She's a known case of preeclampsia diagnosed at 28 weeks. She had a preeclampsia, that means she had an increased blood pressure with proteinuria at 26 weeks. But now, right now, her blood pressure is 130/90, okay, which is normal. And NST is reactive. As I've earlier told you, what exactly is NST? It means when we have two accelerations of 15 beats per minute lasting for 15 seconds over a period of 20 minutes, that is a reactive NST. So NST is fine, that means baby is fine. What is the plan of management in this patient? So answer me in the chat box. So what are you going to do in this patient who is coming for the antenatal checkup? Simple words, somebody is coming for antenatal checkup. Do not try to do cesarean section. Do not try to do what? Inducing the labor, or do not give magnesium sulfate as well. Why? Because the blood pressure is normal right now. If the blood pressure would have been increased along with the proteinuria, I might thought of giving a prophylactic MgSO4 in order to prevent eclampsia, because this magnesium sulfate eventually is going to cause vasodilation. The main reason of this eclampsia, preeclampsia, was what? Vasoconstriction, or you can say incomplete trophoblastic invasion, or you can say unremodeling of the arteries, right? Now, the reason for that only when there was a narrowing of this lumen which would not accumulate the more blood, the resistance was high. But while giving this magnesium sulfate, what happened? Vasodilation happened and patient had an increased blood flow to the organs which prevented eclampsia. So you will not give this as patient is having a normal blood pressure. Followed by that, no indication of dexamethasone because patient is currently stable with a normal blood pressure. You will not go for cesarean section at 33 weeks because she's just coming for antenatal checkup. There is no any other comorbidity seen where you can mark a cesarean section. So what the best answer here is going to be, wait till 37 weeks of termination. You have to wait till 37 weeks of termination. You have to wait till 37 weeks of termination. Now, sir, what is hypertension in pregnancy? We have a different terms. First of all, chronic hypertension. What is chronic hypertension? So it means a pre-existing hypertension in a lady and then she conceived. The hypertensive at the start of pregnancy, which or she's a known case of essential hypertension, or there is a hypertension during the pregnancy which continues till more than 12 weeks postpartum. What is gestational hypertension? So gestational hypertension means hypertension more than 20 weeks of gestation in a previously normotensive woman with no proteinuria, and that hypertension is going to resolve less than 12 weeks postpartum. That is called as a gestational hypertension. Okay, and it happens during how many weeks? It happens during 20 weeks onwards. Prior to that, pre-gestational hypertension or chronic hypertension. What is preeclampsia? When the hypertension is more than 140/90 after 20 weeks with the proteinuria of more than 300 mg per 24-hour urine or 1 plus dipstick, that it is said to be at a preeclampsia. Then we have eclampsia, so preeclampsia along with the seizures, clonic seizures, that is termed to be as an eclampsia. Now, if you talk about the pathophysiology of this, what exactly is the pathophysiology of hypertension of pregnancy? Now, sir, the main reason of this hypertension in pregnancy is due to the incomplete trophoblastic invasion. Trophoblastic invasion. Now, at 20 weeks, when these maternal spiral arteries are there, they change into vein-like structures. And when they change into the vein-like structures, the lumen will get bigger and they can accumulate more blood flow. But at 20 weeks, when there was no trophoblastic invasion, when there was no remodeling of these maternal spiral arteries, the lumen was so narrow that it could not accumulate the more blood. So the capacity was decreased and the resistance was increased. So there is low capacity with high resistance, which leads to the hypertension. Are you getting my point? Now, sir, if there would have been this income, if there would have been this complete trophoblastic invasion, or if there would have been this remodeling of the arteries, what would have happened? So the capacity would have been increased and the resistance would have been decreased, because these maternal spiral arteries, they change into the vein like structures which can accumulate the more blood flow. So there would have been no hypertension. Now, due to this incomplete trophoblastic invasion, there was vasospasm, which lead to the increase in the resistance, which lead to the blood pressure. Is that clear? So this usually happens at how many weeks? 20 weeks onwards. Clear? So if you have a question that what exactly is a pathophysiology of the pregnancy induced hypertension or the gestational hypertension, so remember, it is due to the incomplete trophoblastic invasion. Okay, now sir, eventually when there is a decreased blood supply to the kidneys as well, there is decreased GFR. That is why this preeclampsia is associated with the oligohydramnios, and same way there is a decreased blood supply to the brain as well. There will be a cerebral hypoxia which can lead to the seizures. That's why the preeclampsia will eventually predispose to the eclampsia. That is why the drug of choice for here eclampsia is gonna be magnesium sulfate, because it will cause a vasodilation, and this is a neuroprotective drug as well. Okay, and also it works on NMDA receptors. Now followed by that, this can be given in two regimes. If you give intramuscular plus intravenous, I call this regime as a pre-charged regime. I call this regime as a pre-charged regime. And if you give intravenous only, I call this regime as a Zuspan regime. I call this regime as a Zuspan regime. Okay, remember, as per the previous year questions was asked, what is the loading dose as per the pre-charged regime? It's 10 plus 4, that is 14 grams. So remember, loading dose is 14 grams. Okay, now if prior to given a magnesium sulfate, we check the magnesium levels in the body, and magnesium levels, the therapeutic levels should be 4 to 7 milli equivalent. These are the therapeutic levels before giving a magnesium sulfate. Okay, and then the first sign of the magnesium sulfate toxicity, what will be the first sign? So there is loss of deep tendon reflexes, or there is loss of knee jerks. So what is the first sign of the toxicity of magnesium sulfate? Loss of DTR. And post that, when you give the maintenance dose, okay, make sure you check for the urine output, make sure you check for the blood pressure, and you check for these deep tendon reflexes. Okay, and followed by that, antidote for this is calcium gluconate. Calcium gluconate. This has been again the question asked. This has been again the question asked that which of the following you will not check post maintenance dose, or which of the following you will not check during the maintenance dose. After giving a magnesium sulfate first loading dose, after going for the maintenance dose every 4 hours, 4 doses, when we can skip the next dose? If there are 24 hours from the last seizure. Okay, or one more question was asked that which of the following you are not going to check? You are not going to check the magnesium levels after in a maintenance dose. Okay, you just get to know if there is a loss of DTR, stop the MGSF4. Do not give further maintenance dose. Go with the calcium gluconate as an antidote. Remember that. Now next to that is in hypertension management. Now next to that, what is going to be the management? Now if we talk about the hypertension management, the drug of choice is going to be, now first drug, that is going to be tab labetalol. Okay, and labetalol is an alpha plus beta blocker. Okay, next to that we have the next drug, that is tab alpha methyl dopa. If labetalol is not in the option, go with the alpha methyl dopa. It's a prodrug. Okay, and remember, labetalol, it is contraindicated in asthma. It's contraindicated in asthma. Okay, now next to that, what are the other drugs? We can give calcium channel blockers, tab nifedipine. Okay, it's a calcium channel blocker. We can give hydralazine, it's an arteriolar dilator. Okay, or we can give an alpha blocker, tab prazosin, or we can give an alpha blocker, that is tab prazosin. Clear to everybody? Now further to that, so if we have a drug of choice given for the hypertensive emergencies, for hypertensive emergencies, what is going to be a drug of choice? It is IV labetalol. It is IV labetalol. And alternative to labetalol, do not mark any alpha methyl dope or any other drug. It is IV hydralazine. It is IV hydralazine. So that is all about the hypertensive emergencies. Later on, now next question. A 32 weeks multigravida woman presents with an epigastric pain, headache, and the visual symptoms and proteinuria. So what are the symptoms of this preeclampsia? So we have a patient coming with the 140/90 blood pressure, more than that, and followed by that proteinuria will be seen, and also we'll have a blurring of the vision. Okay, we'll have proteinuria, we'll have headache, neck stiffness, and all nausea, vomiting, epigastric pain, all other symptoms with this preeclampsia. Later on, the proteinuria is 3 plus. What is the next management would be? So in this patient, what you will do first, the next management is we give the magnesium sulfate. Remember that. Why magnesium sulfate? So we will not let a patient land in where? Eclampsia. We give the magnesium sulfate as a prophylactic to prevent the eclampsia. So we also give drug of choice for eclampsia is magnesium sulfate, and in preeclampsia also we go with the magnesium sulfate. Followed by that, we go with the IV antihypertensives. Now in eclampsia, remember, in eclampsia, what is the first management? Anybody in the chat box? Very good. What is the first management? First is going to be, second is going to be, third is, and fourth management. The first step, okay, first step in eclampsia, you go with an airway management. Do remember that secure the airway first, okay. Then followed by that, we'll go with a magnesium sulfate. Followed by that, there should be IV labetalol, and then fourth one, there should be the delivery of the baby. Fourth one, there should be delivery. So if a question mentions what's the first management, remember airway, followed by that magnesium sulfate, third labetalol, fourth is going to be the delivery of the patient. Okay, one more. If this preeclampsia and eclampsia case is given with an epigastric pain, with the hemolysis, with the increase in the liver enzymes, with the decrease in the platelets, think of which syndrome? HELP syndrome. Think of a HELP syndrome. Okay, remember in HELP syndrome what will happen? So there will be a hemolysis. Okay, due to the hemolysis there will be the increase in the liver enzymes. There is elevated liver enzymes. And we have the low platelets. Okay, how many will be the platelets? It will be less than 1 lakh. How much will be the liver enzymes increase? There will be more than 2 times of the normal value. Okay, how much will be the LDH raise? It will be more than 600. LDH will be more than 600. Okay, and the HELP syndrome, the most common presentation of this patient, already you remember that patient will have nausea, vomiting, and the most common presentation will be acute epigastric pain. Next to that, liver enzymes are raised, nausea will be there, vomiting will be there, increased blood pressure will be there, right? What is the cause mainly for this HELP syndrome? Preeclampsia, eclampsia, or somebody who had a history of this HELP syndrome, or somebody who had a family history of this. Now next to that, what will be the management for the HELP syndrome? Now you already know that hemolysis, elevated liver enzyme, and low platelets is the HELP syndrome, but what can be the question asked is the management. Remember, if around 32 weeks she will come and you are able to convince the patient and patient is stable, you can refer the patient to the high center and make sure you send a patient to the high center where there is a facility of a NICU. And if the condition is worse, deliver. If the condition is stable, you can continue the pregnancy. You will not go beyond 34 weeks. Okay, prior to the 34 weeks, you have to deliver. Up to 34 weeks, you have to deliver in the HELP syndrome. Between 32 to 34 weeks, if she's under observation, she is fit for the conservative management, counsel the patient and tell the benefits of waiting 2 more weeks, and then so the lungs will be matured, and then you can deliver at 34 weeks. If not, she cannot wait, condition is worse, deliver. Up to 32 weeks, give steroids, condition is worse, deliver. So in simple words, if the condition is worse and patient is not fit for the conservative management in HELP syndrome, you have to deliver. And what is the end line? At 34 weeks, no matter what, you deliver the case of a health syndrome. So remember this as well. Remember, more than the 2 times is the liver enzyme raise, LDH is more than 600, and platelet is less than 1 lakh. And eventually the management is to deliver the baby. Clear? So that was all about the part 1 of obstetrics and gynecology. We have discussed almost all the main topics. In the second part, we will mainly focus more on the gynecological part, like PMOS, like cancers, ovarian tumors, okay, and the menstrual cycle, then some fibroids, okay. That will be prolapse. That will be our part 2 discussion. In part 1, we'll further from the part 2 we'll further discuss the one of the main important chapters, that is going to be the labor. So all the questions depending upon the types of pelvis, types of presentation, mode of deliveries, we are going to discuss that in part 2. So in this part 1, all the questions, all the topics that we have discussed, okay, the PDF I'll be sharing in the Telegram group, FMGE with Dr. Talib, and it will be also shared in the Meduhub channel. I hope this session was interactive. Okay, so watch at 2x speed if you're watching post recording, and make sure that whatever things I have focused on, whatever times I have mentioned that this has been the question asked in NEET PG and all, please do focus on that as well. So I'll see you in the next part. Okay, thanks for being interactive, thanks for being energetic. So do remember that no comparison. Okay, run your own race. The nervousness is normal before the exam. I know you guys are anxious, you guys are feeling like you have not remembered everything, you're forgetting things, but this is all the natural process. Okay, so all the best, thanks for being interactive. Till then, take care, goodbye, see you, Allah Hafiz. And if you have any doubts related to the session, you're most welcome. Okay.